Well, good afternoon, and welcome to the afternoon session on Heart of a Woman. Hope you've been having a good day. So today we're going to talk about the broken heart, impact of stress on cardiovascular disease. Have any of you have had any stress today? Raise your hands. Me too. So I got this email yesterday that we had to keep our computers on during the weekend to get a very important upgrade coming into the system. So yesterday I wasn't here, I was in another town. So I said, no problem, I come in this morning, I'll turn it on. Well, I get in this morning, I don't have my badge. Without my badge, I cannot get into my office. So a little stress comes in, right? A little packet. But then I did what I almost always do. I went to the rescue of a woman. So I remember Dr. Kurrelmeyer is here. So, Karla, do you have your badge? Yes, I do. Can I borrow it? So we got it taken care of. I go to the office, turn my computer in, leave it on, and hopefully the update will come in. Now, that was just a little bit of stress. That was not really a big stress. But many of us can be subjected to a lot of stress. So if this works, let me move on. Let's see. Yeah. And this has been said for generations. In fact, probably for centuries. And guess what? It is true. Stress can kill. It is not all wives' tale. So what I want to share with you today is where we are a little bit with some of the science behind it, showing that truly stress can be quite harmful. So many of us have heard these stories from friends, relatives. He died from a broken heart. Frequently there's a lot of depression involved and whatnot. Died in the arms of his lover. We always know of sometimes famous people, right? And it's interesting, it's never the wife. It's fascinating, and actually it's very important because when we're counseling patients, men with significant heart disease, as long as you do it with one person. Because most of the time, it's the excitement, adrenaline, the fact that it's something illicit that kicks in, and can cause death. Drop dead in the middle of a heated argument. We've heard that. His wife died, he died 6 months later. That's a very common one, particularly with elderly folks. So there's no question that stress, depression, all of our emotional state is our health. And in fact, there's something called significant life events. And this was published in 1967. The first observation of this phenomenon was in the 40s, where some group of smart investigators made a relation with people getting sicker with tuberculosis and stress in their life. In the 40s, everybody was exposed to tuberculosis. When I went to medical school in Puerto Rico at the age, I got my PPD done, my tuberculin test, and my arm went like this. Because it was endemic in Puerto Rico. I got sick. So they looked back in the 40s at people who got sick and frequently found a lot of important stress involved in their lives in the 40s. But this was a pivotal study. In 1967, reviewing a lot of people, it did an impact score of what they thought was the impact of significant life events. And guess what number one was? Death of a spouse. We will all agree with that. Number two, divorce, marital separation, being thrown in jail. But then there were some interesting things because they found retirement, pregnancy, gain of a family member. In other words, some events that are not really that bad. In fact, some of them might be good. Were also significant life events. So it was not everything bad. It was just something that was some sort of new thing that hit you. But it could be actually good, like getting married. This is only the first group. This list was even bigger, okay? But the important thing that they observed back in those days is that if you score 300 or more, in your check mark of your survey, you have about an 80% probability of having an illness in the next year or two. That illness could be a bad cold. It didn't have to be a heart attack. It could be cancer. It could be, so it didn't have to be necessarily horrific something, but an illness. Between 150 and 299, around 50% chance, and below that, 30%, less than 150. And that was a pivotal study. The first opened the doors to thinking about, wow, you know. And these are some of the examples, etc., because many more. But heart attacks, of course, sudden death, strokes, cancer, infections of different kinds, autoimmune disease, lupus, for example, rheumatoid arthritis, and a whole list. How many of you have been a little bit under stress and cold? Yeah, we all have. And how many of us have been in great shape, feeling good, exposed to people with cold, and we don't get it? Why? Same virus. We're breathing in. So clearly there is a lot of other stuff just besides that little virus getting into our body. So the investigators made this statement. This was a quote from their paper. The body is a finely timed instrument that does not like surprises. We kind of like, you know, we're mammals. You look at mammals, they live in tribes. They love to sleep. They search, they hunt, they search for food when they need it. Otherwise, they're very quiet, you know. If you own a dog, you know that dogs do not like surprises. They don't. They like a nice routine life. And we're mammals. So our body likes it easy. Don't shake it up much, you know. Now, this is all observational studies. We're going to get a little bit more into what we think we know now about mechanisms. So, effect of acute stress in the heart. You know, when you're really in a very acute stress situation, obviously sudden death, cardiac arrest. Cardiac arrest is ventricular fibrillation. You've heard about it. It's electrical chaos. Electricity goes haywire, and the heart just goes like that. And you cannot sustain it unless you give them a shock and hopefully get back to normal rhythm. Frequently, there's an excessive adrenaline that can drive that, and that's where the stress comes in. That's where dying in the arms of the lover can come in. But sometimes even exercise. We always have during marathons people that sometimes drop dead. So even exercise, if you're not properly medicated or whatever, you could. And acute stress being a big one. Acute MI can be precipitated by acute stress? The answer is yes. And there are two mechanisms. This is the most common. We're going to talk about this one too. This is a fascinating disease. This is the bread and butter of most common. So you've heard a lot today about coronary artery disease, plaques in the coronaries and all that. And many of us in this room might be sitting right here. So with a little plaque. This happens for decades, so you know, when we're young, we're nice and clean. Over time, we may form a little plaque. That plaque might stay there till we get to be 100, never do anything. Or they may progress to a point that the artery gets very small and we start having chest pain and problems because blood flow cannot pass well. But sometimes what happens is the lining of the artery, we call it endothelium. This is what Dr. spends his life doing research in, can break. Why? No idea. But certainly it can happen during an acute rush of adrenaline. So if it breaks, there's some chemicals in here that sneak out and they promote a clot. And then, boom, a clot forms there. And then once you form a clot, of course, there is absolute complete cessation of flow and you get your heart attack. That's why nowadays, people with a heart attack, we take them to the cath lab, we try to do it really quickly, and we try to put a stent and open that there. So this mechanism is called plaque rupture. It's one of the mechanisms believed today to be an important mechanism for acute heart attacks. Bread and butter, coronary atherosclerosis, heart attack. This is an unusual condition, but it's very, very interesting. And guess what? It happens more in women than men. more in women than men. So 56 lady, she was attacked coming out of the supermarket. She was being mobbed. She fought like hell and actually ran out and did not get mobbed. Within 15 minutes, started having severe chest pain, came to the hospital, and she looked exactly like EKG, blood test, everything, okay? So she was taken immediately to the cath lab, which is what we do these days. And her coronaries were totally normal, okay? And I don't see this playing. This is not, for the next one, we'll use my laptop, but I don't think, let me see if I can fix it from here. No. Well, it's okay. What the arrow's point is that if you would be seeing the heart contract, this area didn't contract. It was sitting there. And then 12 days later, it recovered. So this was a happy story. The heart recovered, the patient went home. And 1% of people with this condition do recover, thanks God. A few don't, but most do. So this is called Takotsubo cardiomyopathy because in honor of the first person who described it, who was a Japanese. Has also been called apical ballooning because frequently that part of the heart balloons, and also stress-induced, catecholamine-induced cardiomyopathy. So the mechanism is believed to be a rush of adrenaline, catecholamines, causing toxicity to the myocardium, to the muscle. So it's not blood flow issue, it's a direct toxicity of all that adrenaline in the heart muscle, making the heart muscle go, no wanting to work. But it's not global. For some reason, it hits certain parts of the heart only. They have done biopsies in patients that present with this, of course, as a research project, and they have found specific abnormalities in the myocardium when they do a pathology of it. And this is the most exciting part of it. They have an animal model. So they're taking little rats, expose them to a lot of stress, poor little rats, and the rats develop the syndrome. And then they pre-treat the rats with a beta blocker or an alpha blocker, which are, like metoprolol, atenolol. Some of you might be taking it for high blood pressure. And that puts a brake on how much adrenaline gets to the heart. They prevent it when they re-expose the rats to stress. So that's why today, this syndrome is a catecholamine-induced cardiomyopathy. For some reason, it happens more in women. Can happen in men, but the ratio of women to men is significant. Now, this is not the common day variety cause of a heart attack. This is an uncommon condition. The common variety is what we talked about earlier. Good old coronary heart disease, plaque rupture. And you've seen this before. You've seen that there's a bunch of risk factors for coronary disease. Smoking, bad. Genes, well, yeah, if you got bad genes, you're stuck, right? And if you have very good genes, some people have so many good genes that they can get away with murder, nothing happens to them. But the average person is not in either one of the two extremes. So genetics do play a role. The older we're more time for developing those plaques. High blood pressure, high cholesterol, diabetes. But then we throw in that one, big one nowadays in our society. Obesity and sedentary life leads to diabetes through this condition of glucose intolerance. It also enhances hypertension. But then we have this new player, the environment and the stress. And I put genetics here because it's interesting. There are people that genetically, they're cool. It's interesting. Nothing gets them. And then there are others that just a little thing, they go. So there are some genes involved. We see it in our children, right? So genetics do play a role. The environment, obviously, a big one. And our own response to everything is a big one. So here's stress. So what happened with stress? Oh, people smoke more. Blood pressure goes way up. They start eating like crazy, try to eat to relax themselves, so they get fat. You get this cascade here. Even cholesterol goes up. So there's a whole cascade of these risk factors becoming activated, more enhanced from the stress. And again, if we look around, we all see examples of all that in our family members, friends, and so on. So the American Heart Association now considers stress to be a cardiovascular risk on par with smoking, high cholesterol, hypertension, and diabetes. It's a player as important as all those others. So clearly, when the American Heart Association puts that in level, you know that stress has reached a real credibility. It's no longer an old wives' tale. So now, because of that, there's money. Money is always important. So you get grants, you can do research. So now there are investigators spending time trying to learn how all of this happens. Remember what I said earlier. This is because we're talking of heart. We're saying this. Same thing I could be talking on cancer. No question about it. It's been shown. Cancer, autoimmune diseases, infection diseases. So the cascade of stress to illness is not just heart. It's because we're here with you, and because heart is still the #1 killer in women, also in men, in rich, poor, everywhere, that we are stressing the heart. So, look at that. He's put a little rat, he's put in a cage, you start shaking the freaking cage, and then you put a cat. You think the little rat is under stress? Well, I guess it's be better than putting one of you in a cage and checking you and putting a lion, so I guess we have to accept the rats being... And rats are used a lot because actually rats have a lot of similarity with humans. It's very interesting how many of the mechanisms of disease that we explore in rats, we eventually are able to find them in humans. So when they started doing these things, they found those little rats got sicker. They developed plaques. And then they started to look more things. Nowadays, with the use of PET, MRI, you can do PET and MRI in small animals, special instruments that are dedicated just to small animals. You can open a whole door of imaging and finding mechanisms. So they saw that there was activation, more activation of the spleen, of the bone marrow, production of progenitors, which are some cells that go out and stimulate other cells, probably in the spleen. And then they started to think, create a hypothesis, well, maybe there's something happening here that is leading eventually to worsening of the arteries, development of vascular disease. So a little bit more research, using again imaging, shows a lot of activation in the brain in a little place called amygdala. Amygdala. When I'm doing this talk in Spanish for Spanish people, I have to always say, it's not the amygdala here, it's an amygdala here, because in Spanish, tonsils is amygdala. So if I don't make the classification, they'll think that it's their tonsils. And if their tonsils were taken out, they say, oh my God, now I'm in trouble because no. A different amygdala. So this is a little area in the brain, in the hypothalamus. And the hypothalamus, all of this here, in the center of the brain, is where a lot of research suggests that is the area where we get all of our perception of the environment and emotional reactions. Okay? The frontal cortex, we think, is our intellectual thing. This is our bare bottom emotional core in that part of the brain. And the amygdala plays a very important role. So they found that there is activation of the amygdala, which is what this little graph shows, is more signal activation of the amygdala. Okay, very interesting. So what does that mean? So now, the hypothesis is becoming a little bit more developed. Somehow this amygdala, which is a brain, through all the network of connections that we have in our body, is sending signals to, of all places, the bone marrow. Who would have thought of the bone marrow? I mean, we think of the bone marrow as a place where blood is made. Well, guess what? It's a big player. So the bone marrow then releases all these progenitor cells through the spleen, get converted into a few others that are pro-inflammation. And then the arteries start acting up. Hopefully you heard today earlier that I've been in this business long enough that we migrated in the early days as cardiologists being plumbers, where we thought it was just like plumbing. You know, the arteries get clogged up, let's put a bypass. Let's balloon them, and let's put a stent. Now, it's a 180-degree change. Because now we know that blood vessels and arteriosclerotic plaques are a factory of inflammation. There is a lot of inflammation going on. So much so that we actually can measure that inflammation with a little simple blood test. And there's some new trials now being done testing the hypothesis that for certain high-risk patients, in addition to cholesterol medicines and all the stuff we do, if we throw in an anti-inflammatory medication, we may even reduce more the risk of heart attacks. So the entire way we think about coronary artery disease has done a 180. We are no longer plumbers. Yeah. And as Dr. John Cooke likes to say, we are as healthy as our endothelium, because it's that lining of the blood vessel where a lot of the activity starts. And then inside the blood vessel, the inflammation process accelerates plaque formation and all this stuff that eventually affects any artery in the body. Here is a heart attack, but here is a stroke. And in the legs, it could be then problem with circulation to the leg. So all the arteries in the body, kidneys, likewise, are affected by this process. So this is a very interesting concept. So where are we today? Well, very interesting. You can take a little ultrasound of your carotids, and you can see how thickened that wall is. And that is an index of activity of vascular disease. Very easy to do because it's a little probe in the neck to look at the carotid. Guess what they found in this study? They found that intima thickness related biologically, this is not obviously a super relation, but it's a biologic relation with how much activation of the amygdala that person had on an MRI. Interesting. And then this study came up from Mass General back in 2016. They started with 6,000 patients, but they had to do a lot of release because many of these people had cancer, so they had to get rid of them. So they had to do a lot of cleaning their data set, okay, until they ended up with around 500 patients, okay, where they would remove all the other things that could be contaminating the data, and they were looking at arterial inflammation, cardiovascular events, okay, and the brain. They still had to exclude some that didn't have all the tests that they needed to have, so they actually ended up with almost 300, which is still a pretty good sample size. So they found, first of all, that there was correlations. This is all just relations. So relation is not always causation, but it's relation between amygdala activity, arterial inflammation, bone marrow activation, versus the control tissue didn't have it. You may have heard today about calcium score. How many of you heard about that? It's a simple test that we do. Very good after we are 50 years old or older. And if we have plaques in our arteries, the plaque shows some calcium so we can pick it up. So it's basically a marker of disease, of coronary artery disease. And we've known for years that, you know, the higher the score, the less your survival. If you have a score of 0, you are almost immortal, and so on. So there's a lot of data on that. Well, what they found was that, in fact, when they look at activation of the amygdala, as an indicator of stress. They found relation to risk score, the Framingham risk score, which is just clinical score, age and gender. Calcium score, very powerful, 10.7. One was one of the most powerful relations with the calcium score. And then they look at events because people were followed. And they found also relation of activation of the amygdala with cardiovascular events. And this shows it for you guys to see it a lot better. So this is follow-up over 5 years. Subjects or patients with low amygdala activity, this was their survival free of, this is not survival in terms of life or death, is free of any cardiovascular event. So that would be free of attack, of death, of needing a stent, needing bypass surgery. And it's quite impressive. And when they did very fancy statistical analysis, this is where statisticians get their salaries paid. I mean, this is smart thinking, because they had to do a lot of very sophisticated statistics. They found that when they were looking at the amygdala versus inflammation of the blood vessels, 65% of that relationship, was mediated through bone marrow activity. When they actually look at the amygdala versus event rates, 60% of that relationship was mediated by arterial inflammation. So this is a clinical study given credibility to the hypothesis that started in the rats. So now this hypothesis is becoming now a very serious theory. It has gone from hypothesis to theory, and remember that associations are not causation, so you still are in that area where you still are putting things together, but you still don't. Now, can we help? Can we get ourselves out of this mess? Well, very interesting. This is a stress scale score. So you are given a little questionnaire, and it's your own manifestation of how much stress you think you have. And this is the amygdala activation. Human beings, not rats. There's a lot of studies. Even before this hypothesis was where it is now, for the last 20 plus years, people have shown that meditation techniques, relaxation techniques, they do wonders for blood pressure. In fact, people come into our office every day trying to park, and the first blood pressure is 170/90. So we sit down, we talk, and we make some jokes and whatever. And before we're finished, let me check it again. It's 130/70. So we all know that. So there's a lot of data that people who go into a routine of relaxation techniques, their blood pressure comes down. And we know also from thousands of studies of patients, higher blood pressure, higher event rates, strokes, heart attacks, heart failure. Likewise, lower blood pressure, if you treat it, reduction in events. That's why we give pills. That's why we all take some pills, because we want to go this way. Well, relaxation techniques help a lot. All right. And this is the last thing I'm going to show you, because this is a randomized, prospective clinical trial. And in cardiology, we're all about doing this kind of work. You have one group that gets this treatment, one group that gets this treatment, a large sample size, and then we see differences. So these are all survivals of a heart attack. This is a group of very serious investigators. Came out in Circulation, which is one of our most prestigious journals, 2016. So there were 200 plus patients. 151 with cardiac disease were survivors of a heart attack, were randomized to, this is therapy, cardiac rehab, which is routine. We do it all the time. This group was given that plus stress management. This is what we do. This is our everyday thing. Everybody that has a heart attack, we recommend it. We send them for cardiac rehab. 75 patients with CAD, they had no cardiac rehab, no nothing. They were giving pills and have a good life. Maybe some counseling. All right? And the stress management was through using a multidisciplinary approach. So it was multiple ways. And this is the proof of the pudding. 5 years. Percent that are free from a clinical event. Again, this is not necessarily being dead or alive. It's just clinical events. Another heart attack, something serious. Rehab plus stress management. Control, got nothing. Rehab alone. So yeah, rehab is not bad. I mean, you still gain. But the best bang for their bucks was when they combined cardiac rehab with stress management. So I think, we put all this data together. I think the evidence is very strong that chronic stress increases the incidence of cardiovascular disease. Acute stress can precipitate. So a very severe acute stress can be the thing that tips you off with an acute event. Chronic stress is the one that frequently increases our risk for disease. And there's more and more knowledge now about all these complex mechanisms by which the stress induces heart disease. There's equally a group of people working on cancer and working in other areas. So no question about it, we'll be learning more about this in months and years to come. But there's also clear evidence that techniques to reduce stress also help us. That there are today ways to try to look at this. So, bottom line, stay cool. All right, so how much time do we have for questions? I think 15 minutes. That's exactly what I was hoping. 15 minutes, perfect. All right, who wants to go first? Yeah, you have to speak into the microphone so that thousands of people out there on the web can hear you.
Well, thank you for...
There's a little on somewhere.
It's just for the recording.
Thank you for...
No, we should be seeing.
Okay.
Is it on?
It's on. It's on.
Okay, then they should be able to.
Thank you for your information. I am very excited to hear that stress management is a great part of reducing some of the inflammation that the body receives, because I've been a long believer that internal inflammation is a great cause of a lot of the anomalies that we see. So my question is, as we know this in Western medicine, and we're a very interesting society in that we kind of think that if there's an ill, there's a pill. How do we kind of teach our colleagues in medicine that listening to the patient and finding these kinds of things out about patients in terms of their therapy in conjunction with, I guess, traditional ways that cardiologists have been looking at heart disease? How do we get those two entities, traditional medicine and patient care, with that piece, because that's soft science?
So you have asked the $1 million question. I think we have to start somehow teaching our children, who then will become the adults, who then will become the parents, and some of them the doctors, or nurses, or psychiatrists, or sociologists, or psychologists, or whatever. It's a societal issue, and you're absolutely right. Eastern groups have known this a heck of a long time. In fact, everyone has known it. If it's interesting that you look at every religion has some way of praying that is meditation. Okay? If any of you is a Catholic and you pray the rosary, it's one of the most boring prayers there is. But it's relaxing because it's a monotonous cadence that you're saying. Every religion, thousands of years ago, found that some way of prayer, some way of technique to relax. In their own mind, they were also connecting, with God, spirituality, and all that, which can be a subject for another discussion. But all of those techniques were helpful, very interesting. And yeah, the Eastern world have obviously known about this. You guys think I'm very cool, but as a young person, I was pretty anxious. And genetically, I come from a family that has a lot of, so I learned transcendental meditation back in the 80s and was exposed to a lot of these people. And the thing that struck me when I met them is how gentle and peaceful they were. I mean, almost to the point that you were like, come on, speed up. Because I come from, I like things fast. Yeah. They were so relaxed. They were so, naturally. They were not faking it. It was the way they were. Obviously they were practicing techniques for decades. So you're right. This is, the problems that we have is A, societal, and second, physicians will not get reimbursed for any of these. And we live in a crazy world of reimbursement. You're giving 15 minutes to spend with the patient. So unless we do a 180 in how we structure this, or we bring help. So the other possible way is if we are able to bring some help by having supportive people in your practice, hospital practice or whatever, that then can help you with the patients to go through. But the physician has to still play an important role in identifying, see? Because all starts with the doctor identifying the importance of stress. And maybe he or she cannot have the time to do all the therapy, but then can direct the patient to at least where they can start exploring ways to deal with their own stress and whatnot. That's obviously is $1 million question.
Okay, thank you for this presentation. You said something earlier that made me think about the families in response to their loved one being ill. So we talked about the stress management, and I was just curious, what do you all tell family members or caregivers of your patients in terms of monitoring their own stress that might induce more stress to the patient,
So again, it all starts with how tuned the doctor is with all of this. So one of the important things we have to start doing is teaching the healthcare providers. Because I do, because I've been believing this for decades, but many of my colleagues don't. So it all starts with the physician buying into the importance of all of this, because you're right. And one of the reasons perhaps because women tend to be more affected is that women are the caregivers. And there's a lot of data now that we know that women frequently will put themselves as a less important because they're caring for children and parents and husbands, and therefore they may not even be aware of the initial symptoms of a heart attack. We've learned that they often take longer time to get in and get help. Their symptoms tend to be more atypical. So maybe there is a reason why women tend to be a little bit more affected by the whole thing, but men too. I mean, this is a universal problem to every human being. It's not. But I think women has very unique things as the healthcare provider for the family and for not only healthcare. So now it's healthcare, education, financial, you name it. I mean, so I think everything starts with the physicians being in tune with this and recognizing the importance so that they can then ask that kind of a question and provide that kind of support. Alzheimer's is the best model. Most patients with Alzheimer's, including my dad who died from it, are happy campers. Mm-hmm. The family, that's the one that takes the brunt. Yeah. The patient is in la la land. They're happy. I mean, my dad at the end didn't know who I was, but he was happy. He had a big smile. He was a little kid, even though he was 90. So we, the family, were the ones that were being hit with all of that, sadness and stress and everything else. So Alzheimer's, I think, is an excellent model. If anybody wanted to do some, I'm sure there are people doing research on that, on the impact of the disease on the family. Alzheimer's is like the ideal model. Yeah.
Thank you, sir. So you spoke something about calcium score. What is the relationship between calcium score and high incidence of CAD?
So calcium score is CAD.
Oh, calcium score is.
Yes, that's why the test is such a good test. Problem is that it takes some decades before the plaque in your arteries takes some calcium. So if you do the test in somebody who's 40 years old, they might be having some plaques, which we call them soft plaque, but no calcium. So the test will come out good, 0. As you hit your 50s and older, then the probabilities that a plaque in your arteries also contains calcium is 100%, near 100%. So then the test becomes very, very powerful, because if you're 55, we do the test and you have it, you have coronary disease. Now, you have what we call silent coronary artery disease. Nothing has happened yet. Okay. But now you and I can sit down and talk about prevention in a different way, because it's no longer about, well, let's prevent from you. No, no, no. You have it. Now let's talk about preventing the heart attack, preventing the heart failure, preventing the death. You know, the conversation changes because you have heart disease the moment you have a positive score.
Right.
Now, what happens is, because with age, we all can get a little bit of disease. You know, a 76-year-old person that have a little score of maybe 10 or 15, you know, is going to be managed very differently than that same score of 15 in a 52-year-old person. Because once you have hit 76, if all you have is a little bit of calcium, then the probabilities that that's going to catch up with you and cause harm become very, very small. But if you're 52 and you have 35, 40 more years of life and you already have disease, now the odds become very high. So the conversation has to do not just with the score, but the score, the age of the person, all the factors where you are overweight, diabetes, etc. So it's a full. But the beauty of the test is that it tells us you have disease already. So it changes how the doctor and the patient sit down and talk. Yeah.
Thank you.
Thank you for your presentation. Very interesting. My question is specifically on the test again. Is there a specific age where a physician would order that calcium test, or would it be because I have to go to a cardiologist?
First of all, any physician can order it, and number two, even yourself can order it. It's one of the few, because insurances don't cover it. You have to pay. It's $140. It's not a big deal. But because of that, patients can activate themselves. They can call themselves and say, I'd like to have this test. They don't have to have a doctor. It's always better to have a doctor, because then the result goes to a doctor and you can sit down with the doctor. But anybody can order it. Your OBGYN can order it. Your PCP can order it. You yourself can order it. But the biggest bangs for your bucks is once you hit that 50, 55 age or older. Yeah. I've done it sometimes in young people because of their family history. 45-year-old person comes to see me, and their dad died at the age of 35 from a heart attack, their uncle at the age of 38, and you know, then I moved the needle down to a little earlier age. But those are special cases.
I actually have a question. I think about when you're in the ICU, or even just when you're inpatient at the hospital, like, you know, you're being woken up every 30 minutes by the blood pressure cuffs, and there's constantly lights going off and buzzing and beeping. Is there any thought into how that affects people's stress and how that might be making their recovery more difficult?
There's a lot of thought. There's no answers. In fact, since you ask, in October, at my old age, for the first time in my life, I spent 2 days in the hospital. I think God was trying to teach me that, to have more empathy for patients, because I had never been in a hospital. It sucks. And exactly that happened to me. That exact thing happened to me. And I was saying, you know, we have a new program. Methodist is in a partnership with Texas A&M, and we have a program of engineers. There's 32 or so engineers becoming doctors. So they already come in with their engineering knowledge. Now they're going to be doctors. And what we're trying to get them to do is to become innovators and develop new things, to combine the two skills. So I was saying to myself, I need to get one of these kids to develop some way that all this stuff can be done, you know, by some electronics, and they can let me sleep. Definitely, we all know about it. We all think about it. We have no solutions. Yeah, and it is. They come in and they put the cuff and they wake you up, or we're going to draw your blood now, Dr. Q. I look, it's 3 or 4 o'clock in the morning. I say, you couldn't do this at 7? All right.
So we have about
2 minutes left if there's something very short, otherwise.
Oh, no. I hope it's a short question. So, how do you all test? How is the bone marrow addressed?
How the bone marrow what?
Addressed. So you were saying something about.
This is all research stuff.
Okay.
There is absolutely yet not enough knowledge to even hit it as a target for therapy.
Okay.
Yeah. See, the bone marrow is our factory of blood cells.
Right.
Now, normally we only think of one kind of blood cells, right? Red blood cells, which are the ones that give us. But the bone marrow makes everything. That's why, for example, a lot of cancers, like leukemia, for example, are disorders of the bone marrow. The bone marrow goes crazy and starts putting out weird cells. So the bone marrow is a factory of a lot of cells. In addition to the traditional cells that we all know about, red blood cells, white blood cells, lymphocytes, and so on, there's a whole other cascade of cells that can come out. So what we're learning now is that somehow the brain stimulates the bone marrow to put some of these other cells out, and then those other cells out go to the body, connect with other organs, and start creating a cascade. That's all relatively new knowledge. So yet we are not in a place that we can say we have a target we can identify for therapy. That would be obviously great. Or maybe a target that we can hit the amygdala directly and reduce the amygdala activity. You know. So obviously this is wide open, and I would imagine the next 10, 15 years are going to be really exciting. In fact, I have been told that in the next 20 years, the field of psychiatry is going to be revolutionized by biologic knowledge.
All right.
Yeah.
Thank you very much. So if you are planning on going to Dr. Cooke's supplements lecture, that's going to be in here. This room's kind of rotating because of the live stream. Everything else, if you walk down to the other end of this hallway, a volunteer.
The vascular masterclass in ultrasound is really designed to teach somewhat of the basics principles, but we emphasize much more the hands-on experience. In the DeBakey CV Education programs that we run, we pride ourselves in with the concept that we can deliver lectures to you anywhere in the world. We can do that using electronic media.
It has been an amazing course. Small groups, very approachable, very personable, and tons of great information. There's lots of information I can definitely bring down to our practice, to our physicians, and hopefully involve TCD into our daily practice.
Having the ability to talk one-on-one with the physicians in a small group, in a small room, and being able to understand and listen directly from them what's useful.
So we pride ourselves here in providing what we think is the premier hands-on experience. In order to do that, we need two groups of people to be vested in this. Number one, it's very important to us, and we're very grateful for the imaging vendors who bring in the latest and greatest technology and imaging equipment. But in addition to that, it's extraordinarily important that patients participate. We really want you to be scanning with known pathology, and we have a number of patients who very graciously agreed to give up their weekend, come in here, and be subject to applications for this new technology. So in that respect, we think we've got the best of all worlds. Very grateful patients with known pathology and the latest and greatest in imaging technology.
Today we are here to showcase our Accuson Sequoia for the sonographers and physicians at this conference. It's been a real pleasure being able to share our new technologies as well as showcase everything that the Sequoia has to offer.
Having the chance to attend the conference this weekend allows for the opportunity to partner with Methodist and find new and innovative ways to bring products to the marketplace to help improve patient lives.
So I'd like to invite you to come and attend the next Vascular Ultrasound Masterclass. It really excels in having world-class faculty, the best technology that you can get your hands on, and patients with known pathology where you can get actual scanning experience and real-world interpretation classes. So please come and join us in Houston next year. Thank you.
The Society for Vascular Surgery came up with the initiative a few years ago of creating vascular surgery interest group chapters across the nation, with the goal of raising awareness about this great specialty in medicine and fostering interest in vascular surgery in current medical students. The goal of creating this vascular surgery interest group here at Houston Methodist is to allow medical students from the various medical schools in the area to engage in fun and beneficial learning experiences, and to allow them to learn more about our great specialty.
My name is Jacob Watson. I'm a second-year medical student at McGovern Medical School. We really enjoyed coming out today to Methodist Hospital for the Vascular Surgery Interest Group workshop. We learned a lot of great skills and got to practice some interventional procedures and work with the residents and attendings, which was a great experience.
We have multiple ideas in mind, including multiple hands-on workshops, suturing and knot tying workshops, venous access using ultrasound imaging, as well as many other ideas in mind.
I really enjoyed learning about vascular surgery and mingling with the residents. I really enjoyed learning how to use the ultrasound machine to guide catheters into the neck. And I think it's really a really good experience this early on in my medical education to get these sort of hands-on skills before I go to the clinic, just to be more prepared and understand more about what it means to be a vascular surgeon.
We will also have industry-sponsored events during which medical students will have the ability to play with demo gadgets as well as deploy stents and look at grafts as well as catheters and wires that we use on a daily basis during our interventions. We will also have meetings during which students will be giving tips and tricks on how to be more competitive applicants, as well as answer them any questions regarding their application and match process, which can be a scary and stressful stage of these medical students' career.
My name is Kyle Shepard. I'm a third-year medical student at McGovern Medical School, and today I got to learn how to do ultrasound guided central lines with Houston Methodist. There's the practical skills that you can walk away with, like how to place a central line, but also just like knowing how to network with other people and making sure that you are asking the right questions and prepared for the next step when you're looking at applying for residencies.
We also aim to engage students in more hands-on workshops, as well as allow students to be more aware of what vascular surgery is all about and help increase the interest in this great specialty.
Hey, I'm Don Yap, and I'm a nurse education specialist here at Houston Methodist Hospital, the Texas Medical Center. I was asked to be here today and be a guest speaker on pacemakers and EKG rhythms, as well as give an overview on ventricular assist devices for the breakout sessions.
Hi, my name is Tracy Kennan. I work here at the Houston Methodist Hospital. I'm one of our nurse clinical experts. My specialty is in transplantation, heart and lung transplantation, along with mechanical support.
The concepts of blood conservation have really evolved over the last couple of years to really include a team-based approach. And we're trying to go through and discuss in a team-based approach how to limit blood transfusion or do blood transfusion but in a responsible way to benefit patients, to be cost-effective modalities.
Today, while I'm here at this conference, you're going to enjoy meeting me upstairs when we talk about ECMO, extracorporeal membrane oxygenation. We'll do some simulation, we'll run through some plays, get your hands on, and you'll have a lot of fun today.
I'm very excited to have my team here as we grow our CV program at Willowbrook, and to be able to bring the techniques of our HMH, as we all know, standardizing that care to the suburb area, so we will be able to provide the same paramount of care to our patients.
So I'm most excited about doing the hands-on things, working with machines. I heard we're working with the ECMO today, and so I'm excited to use that and kind of get more experience with that so I can use it on my patients.
The one that interested me most, being here with the simulation. I love to be in the simulation, especially with, doing the sternotomy. I haven't done it yet, and it really helped me, especially the gowning up and the preparation of the sternotomy.
So this session is going to be live streamed, and the idea is for us to just have a discussion, and I think it'll be good. We'll have a little fun with this. The microphone is going to be passed around, so if you have a question, please speak into the microphone. It won't actually amplify your voice in the room, but it will allow you to be heard on the live stream. Okay? All right. Tyree's going to give me the word. And George, team, they do a spectacular job filming everything and turning it into educational material. Good information on that website. So we have a lot of educational activities. Every week we've got something going on in heart and vessels. So if you're interested in the cardiovascular system, this is a great website to take a look at. For example, our visiting professors, it's the last page of your program. So here's your program, Heart of a Woman, and then in the last 2 pages there, at the top it says DeBakey Education, and there's a website listed, so you can go there. And we have visiting professors from all over, international, mainly national, but great people speaking for our grand rounds. sometimes we have internal speakers, our own faculty, talking about different aspects of cardiovascular disease. Welcome, guys. I'm John Cooke. I'm chair of the Department of Cardiovascular Sciences at Houston Methodist Research Institute. And welcome to this breakout session at Heart of a Woman. This breakout session, we're going to talk about supplements for heart health. So cardiovascular supplements. Is there any utility? Is there any truth to cardiovascular supplements? Which are good for you? Which might you want to try? So have a wide-ranging discussion about that in the next 40 minutes. So maybe I'll just start out with a few remarks about the supplement industry. What we're talking about now are vitamins and minerals and herbals, natural products, nutritional products that are sold everywhere in the grocery store and the health food stores. Is there any truth to the claims that are made? Well, I should say that there is some regulation. The FDA does have some regulatory oversight over the nutritional supplements. They actually have, there's a regulatory box that governs the health food supplements. It's called dietary supplements. And they're regulated by legislation that dates back to the 1980s, the Dietary Supplement Health Education Act, also known as DSHEA. And that legislation does provide some kind of governance of the health food industry. But there's so many products out there, so many companies, it is difficult for the FDA to do quality control on all of that. And they can't. They have to be a little bit selective about what they decide to look into. So if you are taking health food supplements, I think the one thing that I want you to get from this session is that it's caveat emptor. You have to really do some of the homework yourself to understand if the supplement is useful. Are there supplements that are useful? There are a few, I think, that have good evidence of their utility. One that I'd like to start with is Chinese red rice yeast. The Chinese red rice yeast has been shown to lower cholesterol. Some of the best studies were done out at UCLA in randomized clinical trial fashion, showing that Chinese red rice yeast could lower cholesterol. And it makes sense because our statins are derived from Chinese red rice yeast. It's not well known that a guy by the name of Endo, a Japanese scientist at Sankyo, the pharmaceutical company Sankyo, discovered that Chinese red rice yeast contained something called compactin, which was basically an inhibitor of cholesterol synthesis. And from that, the statins sprung from that observation. So that's a good one. But again, I can't vouch for any particular product. And I have once had a patient bring to me his Chinese red rice yeast for me to take a look at. And I looked at the ingredients, and most of it was niacin, actually, in the pill he was taking. He was complaining because the Chinese red rice yeast was making his face turn red. Well, it wasn't the Chinese red rice yeast that was making his face turn red, it was the niacin that was causing. And it was probably the niacin that was lowering his cholesterol because there wasn't much Chinese red rice yeast in this pill. So, I mean, that's kind of an exemplary of the field. You need to do your homework in terms of what's in the compound you're taking. Quite a few years ago, it was 15, 20 years ago, one of my children was having some emotional problems. One of my kids had depression. And there was some evidence, there is good evidence that omega-3 fatty acids can help with that. So I started myself looking into omega-3 fatty acids. And at that time, again, that was about 15, 20 years ago, a fellow by the name of Tom Saldine had looked into the different fish oil products in the shelves in the supplement store. And what he found was a tremendous heterogeneity in the healthfulness of those products. The way he looked at this is he looked at the effect that the pills had on people that were taking them. So he did a study, a controlled study, where he looked at the benefit of the fish oil products on one measure of oxidant stress in the blood. Name of the test is T-bars. It's just a way to measure oxidative stress in the blood. And in general, the fish oils reduce that measure of oxidative stress. So that was a good thing. But there was different levels of efficacy of the fish oil. And there was one fish oil that made it worse. You know, it was oxidized already. Do you know what the poor man's test is for oxidized fish oil? How do you test for it? How do you determine if it's good quality? You bite into the capsule. And if it's really fishy, if it really smells fishy and tastes fishy, then it's oxidized. You know, so it's not good. Really good fish oil. The one I found, and again, I have no interest in the company, but it was Carlson's fish oil. At the time, that was a really good product, and I learned myself from talking to the CEO, a woman, at the American Heart Association. She had a booth there at the American Heart Association, and I started asking her some penetrating questions about her fish oil, and she pulled out her HPLC tracings, high pressure liquid chromatography tracings of her fish oil. You know, so she went to all that trouble to prove that her product was pure. They purified it. She derived it from the fish, the actual fish, near Scandinavia, in the cold waters in that area. That's where her fish oil came from. But you know, fish don't make fish oil. Cynthia doesn't believe me. Fish don't make fish oil. They get their fish oil, their omega-3 fatty acids from plankton in the water. So the small fish eat the plankton, the krill, and the larger fish eat the small fish, and that's how they get their omega-3 fatty acids. So. Yeah, and in fact, there is a company that derives its omega-3 fatty acid from plankton, from krill. So krill oil, that might be a better product because you're not going through the food chain. You know, it's krill oil. So I thought I'd just start with those preliminary remarks, and then maybe you guys have some thoughts. The last group that I was talking to brought up probiotics, and I don't know anything about probiotics, so I learned about probiotics because we had a PhD who was a student who had studied that, and we learned from her. So I know that we've got nurses in the room here that have their own insights, and other people that have insights, health providers that may have insights. So if you have a comment to make or have a question, that's what we'll do now. We'll just have a discussion, open discussion about supplements in general. So Luann has the microphone. Does anyone have a question or have something to say to get started? Yes.
Thank you. There's been a big talk about turmeric. How does that help?
Turmeric, okay, so that's a spice that's used in Indian cooking, and we learned today actually from our chef that he uses it in his Mediterranean dishes also. Well, turmeric has antioxidant properties, and it is one of these, it's a part of an ethnic cuisine that actually is good for you. So Indian plant-based, highly spiced diet seems to be good for the blood vessels. There are even some trials where they looked at the effect of turmeric on the ability of the blood vessels to relax, and turmeric seemed to improve blood vessel relaxation. So for me, that's an indicator of vascular health, if the blood vessel can relax better. I would say, you know, without any evidence from randomized clinical trials, that it's probably good for you to have some of that in your diet, turmeric. And in general, you know, the spices used in Indian cuisine tend to be antioxidants also. So I think they're generally, I think most of us cardiologists think they're generally good for you. Nice question. Yes?
What's your thoughts on CoQ10?
What are my thoughts on CoQ10?
CoQ10 with heart stuff.
Yeah. How do you pronounce your name?
Sinead.
Sinead.
Sinead, yeah.
That's
It's
a
Irish.
good Gaelic, Irish
yeah.
name. Sinead. Wonderful. That's a great question. Thank you, Sinead. So coenzyme Q10 is an antioxidant vitamin, and they may have some utility in people that are having symptoms from their statins. So statins do lower your endogenous levels of coenzyme Q10. Coenzyme Q10 is an endogenous agent in our cells. Our cells need that coenzyme Q10 to function properly. And statins lower coenzyme Q10, so that's known. And if you take coenzyme Q10, your coenzyme Q10 levels go up. So if you're on statins and your levels are low, coenzyme Q10 can bring it up. Is it useful? Well, it seems to be useful in people that have myalgias from statins. So if you're having muscle problems, then you might want to take it so you can stay on your statin. I'm actually not sure what the dose is. I think you'd have to, there's actually been some clinical trials looking at coenzyme Q10 and its benefits, for example, in heart failure. And those studies have been kind of plus minus in terms of improving heart failure. There's one study I know of that was positive, showed some benefit in terms of people's ability to walk. And people in heart failure seem to have some benefit from coenzyme Q10 in that study. Another study where it didn't seem to help very much. So I'd look into the literature and see what doses they were using in those studies. Okay. Yeah. Good questions. Cynthia has a question. Cynthia, by the way, after this session, is going to be doing one on the heart and nature and healing. And she's going to be teaming up with Dr. Inga Ford, who's going to be doing guided meditation, talking about meditation and its benefits.
Thank you. The question I have is, what impact do beets have on circulation and heart wellness?
Oh, that's a great question. So what impact do beets have on heart health? Well, there are good clinical trials, randomized clinical trials, showing that beet juice can lower blood pressure. And again, I'm not sure what the dosing was, but good studies showing some benefit of beets. And then the product you have in your hand is a beet juice product. Yeah, thanks. It's a beet juice product. It was from the company that was sponsoring us today, Human. And that is a beet powder, powdered beets. I think that's just basically similar to beet juice. I've tasted it. It's pretty good. I should say that I'm on the scientific advisory board for this company, and I think it's quite a good company. And they have some data to support the use of those products in terms of improving blood vessel function. So the reason beet juice is good for you and these products are good for you, in general, nitrates are good for you. Dietary nitrates in fruits and vegetables are good for you because nitrates get converted to nitric oxide by your blood vessels. Actually, it's a little bit more, it's really an interesting cycle. When we eat nitrates in our salads, so salads, vegetables that are colored have nitrates, beets have a lot of nitrates, that gets absorbed in your salivary glands. Your salivary glands concentrate nitrates, and the bacteria in your mouth, our microbiome in our mouth, convert it to nitrite. Nitrite gets swallowed, and in your stomach gets converted to nitrous acid, and that's actually really potent in terms of killing things that you're eating, pathogens that you might have taken in accidentally. And then it gets absorbed into your gut, into your bloodstream, and it gets converted to nitric oxide in your blood. So there's this cycle of nitrates and nitrites
in our blood that is very healthy for our gut and healthy for our blood vessels. That's probably more than you ever wanted to know about beet juice.
That's interesting.
Thank you.
And these don't taste like beets. That's the best part. For me.
Thanks, Cynthia.
Dr. Cooke, I'm glad you mentioned that because that's what I was going to ask you. If the benefit of a fresh vegetable, the beets, because that's what we're discussing, is better than something that is processed. And then because this is what I was informed, or that the saliva in our mouth when we chew is what we need in order to get the benefit. And so that's what you were talking about.
Yeah.
So can you expound on that a little bit?
I think you're quite right. I mean, this is always, for me personally, it's my bias is that if we can get it in our food, that's a better way to deliver whatever is good for you. The antioxidants, the nutrients, it's better if you get it in your diet, I think. And, you know, if you're not getting it in your diet and you need a supplement, well, that's good. Okay. But I personally think it's probably better to get all these nutrients in your food. So I think what we heard today from the chef about the Mediterranean diet was good advice based on the data that's available. The first study that showed that the Mediterranean diet was very good for us was called the Lyon Heart Study, and they basically tested the Mediterranean diet versus the American Heart Association Step 1 diet at the time. They had to stop the study after follow-up for 2 years. 2 years the patients were in the study, they had to stop. The Data Safety Monitoring Board said the difference between the two arms is so significant that you've got to stop the study. And when they unblinded the results, it was the Mediterranean diet that was much better than the low cholesterol diet of the American Heart Association. And there's been a couple of more studies since suggesting that the Mediterranean diet is the best one for our blood vessels. The ones I'm most familiar with are studies where they put people on a Mediterranean diet and tested their ability of the blood vessels to relax. So there's a number of ways we can test the ability of the blood vessels to relax. In the study that I'm thinking about, they used ultrasound to assess the ability of a blood vessel to relax with increases in flow. And the Mediterranean diet helped. So I think it's probably the best diet for you. That being said, as you heard, I tried the intermittent fasting thing. It hasn't worked for me. For me, it turned into intermittent feasting. So I ended up, I got on the scale this morning, I was 4 pounds heavier.
Dr. Cooke, what about some of the people that have used dietary supplements or pills per se to help lose weight, but then they have an effect on the heart and not in a good way?
Oh, that's a really great question because a few years ago, you guys may remember the fen-phen regimen.
I remember that.
Yeah, and people were losing weight on that. It increased metabolism, the fen-phen medication. But then it turned out that it was also causing valvular problems, valvular disease. So we don't really have a medicine to lose weight right now. And I'm skeptical that that's the right way to do it. I think it's probably better diet and exercise is probably the best way. It's hard, but it works. Yeah.
It's on. It's on. I have a question about olive. I have a question about olive oil extract. Is it true to lower blood pressure? Have you heard that?
Olive oil extract, I haven't heard of that one, but olive oil itself is what we heard from the chef Luca today and from our dietitian Angela Snyder was that that's a great oil to be working with, olive oil. It's a polyunsaturated fat. We need some amount of fat in our diet. And what you want to avoid is the saturated fat. So saturated fat are things like butter and hard cheeses. And then the polyunsaturated things are like softer cheese, but even better, the oil, omega-3 fatty acid, the olive oil. And then, of course, fish oil is another type of oil. You can't use it for cooking very much, but it's a good oil to be taking. Another one, also you can't use it really much for cooking, but another one I think is very good for you is flaxseed oil. Flaxseed oil is the only plant-based source of omega-3 fatty acids, flaxseed oil. And that oil is, it's very delicate. You have to keep it in a colored glass bottle and keep it in the fridge. And I use that with balsamic vinegar on a salad. So I mix the flaxseed oil with balsamic vinegar. I think that's actually better for your salad than olive oil because the flaxseed oil has omega-3s in it. Yeah. Any other questions? Yeah, we have a comment back here.
What do you think about Atkins diet? Atkins diet and the vegan diet?
So what do I think about the Atkins diet?
If they're good or no?
Yeah. I'm a cardiologist, so I'm very negative about the Atkins diet. It might help you lose weight, but it doesn't do a good job for your blood vessels. And I think poor Atkins, actually, he succumbed to a myocardial infarction, is my understanding. Yeah, so I don't think it's very good for your blood vessels. And the other diet you asked about? Oh, vegan diet. Well, I would say that it's generally speaking, it's a good diet. Vegetarian, plant-based diet is generally better for you. I mean, there's a lot of similarities between the Mediterranean diet and the vegan diet. If you take out the meat from the Mediterranean diet, but you kind of have a vegan diet, don't you? I mean, it's plant-based regimen.
Sometimes they use a lot of fried food, like chips, potatoes, fried potatoes. That's not a real vegan diet. They eat them a lot.
Really?
Yeah, they do.
Yeah. I think that would be vegan cheating. But no, that's funny that you mentioned that. I mean, that was the problem I had with my diet, right? I mean, I was sticking to the rules of the diet, but you know, that was intermittent fasting. But there was the in-between part where I was eating that wasn't working for me. But I think vegetarian diet is generally pretty good for you. It's not something that I think the fish is so good for you. Omega-3 fatty acids are so good for you. I think that's, I would say if you're add a little bit of fish to a vegan diet, then it's not a vegan diet anymore, but it's better probably for you. It's a Mediterranean diet. Yeah. Any other thoughts about that? About
I was just going to make a comment by going vegan. Used to step on the scales all the time and fluctuate 3 or 4 pounds, but now by going vegan, I keep stepping on the scales and it just never changes.
In a good way.
In a good way.
Yeah, that's good. And how about your cholesterol level and blood sugars? Have you had any benefit on that with the vegan diet?
I dropped my LDL 40 points within 10 months.
Wow. Wow, that's spectacular. I think, the plant-based diet is better for the planet also. It's better for us and it's better for the planet. So I think generally I think a vegan diet is good, except I personally would probably add a little bit of fish to it.
I eat fish once a week.
Thank you, Dr. Cooke. Going back to that flaxseed oil that you're talking about.
Flaxseed oil, huh?
Yes. Would you recommend the flaxseed supplements? And what about the grapeseed with resveratrol?
Okay. So would I recommend a flaxseed supplement? Again, I can't really recommend any supplements because you have to do your own work on that. There's so much variety. And flaxseed was very vulnerable to oxidation. I would say again, the whole food is probably better than the supplement. And the flax seeds themselves contain fiber. So if you get ground flax seeds, that might even be better than just the oil itself. But I haven't used the flax seeds myself that way. Has anyone else used flaxseed meal? Tell us about that. How does that work?
Well, I'll use the ground flaxseed and just put a couple of tablespoons in cooking my oatmeal.
So repeat that. That's a really good comment.
I'll put a couple of tablespoons of flaxseed in my oatmeal when I'm cooking it for 10 minutes or forever how long. And then I'll also just sprinkle it on salads.
All right. Okay. That's really good. I like that. Someone has a question back here. No? Okay. Another comment? I'm going to try that. So ground flaxseed, where do you get it? You get it
Whole Foods.
at Whole Foods? So ground in a small bag.
Yeah. And I keep it in the refrigerator. I don't know if you should, but
yeah, that makes sense to me because you don't want to get oxidized, and that process speeds up under higher temperatures. So lower temperatures, we know that reduces oxidation. So that makes sense. So on your few spoonfuls on your oatmeal and on your salad, that's good. Yes.
Yeah, and I was going to say I put it on yogurt in the morning with fruit,
okay.
you know, and just mix it in. I keep it in the fridge as well. So I don't know, I was told to keep it in the fridge. And also, is there any, I love salmon. Is there any way you can eat too much salmon? Because I would eat it nearly every day, but sometimes they say, you know, like tuna and salmon, you know, I know it's mercury or something, I don't know, I just want to, can you eat too much
really
salmon?
Good question. Really good question, yeah. You know, there was actually in Sweden, the sailors, they were, you know, sailing in the North Seas, they would feed them salmon, and they actually had, in their contract, they had a limitation as to how much salmon they would be fed, because they're always getting salmon. But I think it's probably, the more you eat, the better it is for you, but the fish is good for us, but we're not good for the fish. That's the problem. I guess, you know, the concern you raised is about the food chain. If you're eating salmon that are, you know, free living, well, they're getting exposed to everything that's in the water these days, and you worry about the plastic that's in the water and the other things. One way to avoid that, if you still want to get omega-3 fatty acids in your diet, and you should, is by taking a krill oil supplement. We were talking about that earlier. Fish don't make fish oil. It's the krill that make the fish oil. K-R-I-L-L, krill oil, right. And again, I don't have a particular brand to recommend. You'd have to do your homework on that. Someone else had a comment. Yes, there's lots of comments. Start over here.
I just had a question on the flaxseed.
And then you're next.
She was saying that she grounded it. Would it be okay just whole on the salad?
The problem with the whole flaxseed is that it's hard to digest. It might just pass right through you. So I think you're using ground flaxseed, right? Yeah.
Okay.
Yeah. And Wada had a question.
Yeah. My question is about coconut oil, because I've been hearing a lot of people saying it's better to eat coconut oil than vegetable oil. So
well,
what's your take on that?
So cardiologists are not really proponents of coconut oil, because coconut oil is one of these oils that is highly saturated. So it's kind of just like the opposite of olive oil. Olive oil is polyunsaturated. Coconut oil has a lot of saturation, so it's a little bit more like butter. It's good, tastes good, not quite as good for your blood vessels.
Thank
Sorry. I'm disappointed too. Well, who was it? I'm trying to think of the woman, the wonderful chef, the woman, as you said, everything in moderation, especially moderation. Julia Childs. Julia Childs said, everything in moderation, especially moderation. So maybe a little coconut oil. Can you cut that out of the tape? Yeah, there's some more questions over here, I think.
We were just wondering where you could get the krill oil, doctor. Do they sell that at Whole Food Market? Yeah, they sell it at Whole Food.
Yeah. So I think the krill oil you can get at health food store, and I think at some grocery food stores you can get krill oil also.
Thank you. Vitamin stores have it.
Yeah.
Okay, so we're stranded on a desert island. We can eat 3 foods to be heart healthy. What are they going to be?
Oh, well.
And we are not restricted by what's on the island.
Yeah.
It's just poof, you can have it.
Well, we're going to leave the coconuts up in the trees, I think. But, yeah, there you go. Fish, of course, so that'd be the first thing I would look for. I would look for a source of plant-based protein, like some nuts would be good. And you want to have some vegetables because you want to get your micronutrients. And I have to look in your desert island what vegetables are available.
I don't know about beets. String beans and cauliflower.
And I guess is it possible that we could get some red wine on your island? Because that would be great.
Yeah, that takes care of the fruits.
That's right. Any other comments or questions? Well, this was a lot of fun. If anything else comes up, if you have a question, you get my contact information from the website, which is in your program. Yeah, I really enjoyed this.
I still have the reservation on the coconut oil.
Thank you, guys.
Not so much for your heart.
What about palm oil?
Same.
That's a good question, though. Thanks for bringing that up, because there are differences between oils. Some are good for you and some not so much.
Yeah, but then what about palm oil?
Hi, my name is Mahesh Ramchandani and I'm a cardiac surgeon at the Houston Methodist Hospital, and I'd like to invite you to the 11th Annual Re-Evolution Summit.
Our goal is to introduce you
to the current state of minimally invasive cardiac surgery. The international faculty are chosen because they're leaders in the field and because they are great educators. There will be lectures, panel discussions, demonstrations, and a rich and rewarding hands-on experience in our state-of-the-art training lab. The topics will include minimally invasive techniques, both robotic and non-robotic, for coronary bypass surgery, aortic valve replacement, mitral valve repair, and atrial fibrillation. You'll also be introduced to sutureless valves and other innovative technologies that help to facilitate minimally invasive cardiac surgery. There will also be instructions on how to use advanced imaging to your advantage. This conference is for anyone who is interested in cardiac surgery as it should be practiced in the 21st century. There is an excellent social program and the networking opportunities are wonderful. You will certainly enjoy these greatly. So, come join us April 2nd and 3rd, 2020. It will be a very rich experience that will not disappoint you. You will take away many nuggets and pearls that you can use in your practice.
Hello, I'm Alan Lumsden. I'm the chair of the Department of Cardiovascular Surgery at Houston Methodist Hospital. On behalf of the DeBakey Heart and Vascular Center, I invite you to join us for our inaugural DeBakey CV Congress, focused on advanced interventional cardiovascular imaging and robotics. The conference will take place at the Houston Methodist Research Institute and the Texas Medical Center here in Houston, Texas. The new program for all cardiovascular interventionalists will teach cardiovascular imaging and interventional techniques in an intensive hands-on setup. You'll learn by doing techniques such as 3D planning using CT and MR image data sets, intraoperative image fusion, 3D acquisition for interventional guidance. So by the end of the program, you should be able to apply these imaging and image guidance and robotic techniques to improve your clinical practice. I hope you will join us for this innovative new conference, and I look forward to seeing you in February 2020. Thank you.
One in 4 women around the world die of heart disease, making it 10 times more likely than breast cancer to cause death. However, the symptoms of heart disease may be different for women and may be overlooked. As a result, many women don't get the treatment they need. Hi, I'm Dr. John Cooke, Chair of the Department of Cardiovascular Sciences at the Houston Methodist Hospital, and I invite you to attend the 3rd Annual Heart of a Woman Conference. This special event is designed for members of the public and healthcare professionals who want to recognize, prevent, and treat heart disease in women. Our faculty will talk about how heart disease affects women, how it is detected and diagnosed, medication options and lifestyle strategies to prevent this deadly disease. You'll get practical health tips and enjoy a delicious heart-healthy lunch and cooking demonstration from Master Chef winner Luca Monfe. In the afternoon, we invite you to customize your experience by choosing small group breakout sessions. Here you'll have the opportunity to learn more about the topics that matter most to you, such as nutritional supplements, healthy cuisine, fitness advice, and more. Join us on Saturday, February 15th, 2020, at the Houston Methodist Research Institute for this exciting educational experience. I look forward to seeing you there.
There are a lot of conferences and everyone gives lectures and data, but this is one of a kind where you go in hands-on, using the new technology, experimenting it, getting a feel for the technology, and learning hands-on exactly how these procedures are done and why this technology is so important.
The ISCVS symposium that we are holding here at Methodist Hospital in Houston, Texas, is the largest hands-on symposium in a variety of interventions in the world. It has not been done or achieved anywhere else. This is something that's so unique because we have here state-of-the-art technology, the newest innovations in endovascular field to train and teach physicians how to use and implement this to provide better patient care.
Having such a great wealth of resources and having different x-ray techs at every station, having all of the equipment available to do the jobs that we wanted to do, it was really a great opportunity. It was like having a big endovascular playground where you could test out all of the different equipment in a controlled environment. As a physician assistant, being able to work with the different surgeons and really grow my depth of experience has been a great opportunity.
Well, there's certain things that you can't learn in the classroom, and obviously when you're working as a clinician, the mistakes are costly. So here, you can experiment with the devices, you can try things you've never tried. You have experts kind of guiding you and giving you advice as to how to deal with complications and the procedures. And that's always what I'm looking for. I'm always looking to increase my speed of learning and content. And I think that this hands-on approach is very effective for that.
Okay.
Good afternoon. I am Mawash Kasi. I'm a heart failure and transplant cardiologist, and I've been asked to talk about pregnancy and heart disease in women. My intention is, of course, not to dissuade anyone from pregnancy. That's not the intention. But of course, several issues come up whenever people get pregnant, and if they have any conditions that may require cardiovascular care, they can be very, very sick at that time, which is where my role comes in, particularly if they're suffering from heart failure or need advanced heart failure therapies. And in certain situations, we have to start them on medications, and how that interacts with pregnancy can become very complicated. So women, of course, in the United States, more women are getting pregnant at a later age, which is when they already have comorbidities. This includes hypertension, diabetes, and also coronary disease is far more common in women than we actually expect it to be. We generally, the bias is that if you see a young woman, she probably doesn't have any coronary disease or she doesn't have any risk factors, but that's actually not true, and that is exactly why heart disease is missed in a lot of women. What I'm going to do is I'm going to start by talking about something that I'm a specialist at, which is peripartum cardiomyopathy. I'm going to go over a case, and then I'm going to talk about that specific condition. And then any other questions that you all have about pregnancy and how to manage pregnancy-related conditions, or any day-to-day management with patients who are pregnant, we'll open the door for questions then. So what we'll be talking about, it's a condition called peripartum cardiomyopathy, which means that when you're pregnant or at the end trimester or after pregnancy, you get diagnosed with heart failure. So I'm going to talk about the definition and how common is it, what are the predisposing factors for this condition, what to watch for in terms of signs and symptoms, and how utterly confusing it can get when you're pregnant. And then how do we proceed with the pregnancy? Of course, if you're pregnant, and women who in this room who've been pregnant or know about pregnant women will realize that, pregnancy is special. You don't want to lose your child when you're pregnant. And at the same time, how does care change once you have heart failure? Then most women ask the question to breastfeed or not. And my view about breastfeeding when you have this condition has changed based on the newer data. So we're going to talk a little bit about that. It is a controversial topic still. And what is the prognosis? How do women do after they've been diagnosed with this condition? And does it have an impact on your future pregnancies? And could we consider being pregnant in the future or not, is a question that most women ask. So this is a case I'm going to talk about first. This was a 21-year-old female who presented to the hospital for worsening shortness of breath. She complained about worsening fatigue, worsening lower extremity edema, worsening shortness of breath. So how many women experience that when they're pregnant? Probably all of them, right? So it becomes exceedingly hard to distinguish normal pregnancy from a condition like this, particularly if you can look at her age. She's 21 years old. Who would have imagined? So in her history, what was significant was that she had delivered a month prior to her first child, and she did not have any known medical history, no history of hypertension, diabetes, no other coronary artery disease that we knew of. And there was no significant family history of heart failure or sudden cardiac arrest. So whenever you're trying to figure out if people have some genetic predisposition, the two questions we asked across three lineages, preceding and your children and your siblings, whether they've had any heart failure or if there has been a history of sudden cardiac death less than 45 years of age. Those are significant events. So that counts as positive family history for possibly cardiomyopathy. So when we talked to her more about her symptoms, she said that she would get symptomatic if she would bend forward. That's a condition called bend-apnea, which is indicative of having high pressures in your heart, high filling pressures, as well as low cardiac output. Also, she complained about orthopnea, which is when you lay flat at night, you get short of breath, and you're trying to use more and more pillows to sit up. I typically ask my patients that, what is your arrangement at home to sleep? Do you sleep on the bed or are you sleeping on a recliner? And it's remarkable how more than 60% of the patient answer, oh, I don't sleep on the bed anymore. I go and sleep on the sofa, or I go sleep on the recliner because it's really hard for me to breathe. So that's basically orthopnea. She also complained of profound lower extremity edema. She thought that these symptoms are just part of her pregnancy. Of course, she was pregnant for the very first time also. When we did her physical examination, she had elevated neck veins called elevated jugular venous pressure. She also had a systolic murmur. Her heart was big on examination, so she had a deviated apical impulse, and she also had pitting edema in her lower extremities. So some things can occur with pregnancy. Of course, the lower extremity edema is common, but if you're seeing somebody with an elevated jugular venous pressure or a hepatojugular reflux, which means that if I press on your liver, your neck veins become bigger, that is not normal. So then we did an echocardiogram of her heart, and if you look at this image, this is basically an echocardiogram image, which the atria or the upper chambers are lower, and the ventricles or the lower chambers are on the flip side. So if you see, usually a heart, when it contracts, it's robust. There's actually, at her age, you should actually see these walls come in and kiss each other, because this is what a normal heart should be like. But her heart barely moves, and her atria are very enlarged. Her right ventricle is also enlarged, and it also barely moves. And if you look at this portion of the heart, there is very profound recesses. This is a condition where the heart can become non-compacted, meaning it goes into or degenerates into an embryonic form, where your heart, when it's going through the process of development, it goes through this phase of non-compaction, and then it becomes compacted and becomes nice and smooth. But hers looks like it has regressed to that form. So non-compaction in itself is a form of cardiomyopathy. And an interesting fact is that women, when they're pregnant, can for some reason become non-compacted, and once they deliver, they become compacted again. But that can happen in normal situations also. There was a study done on just normal pregnant females who did not have heart failure, and when they did the study, they saw that a lot of women went through this non-compacted phase, and then later on their heart muscle lining smoothened up once they delivered the baby. So that's why whenever people come in, and if a pregnant woman has just this non-compaction, I wouldn't possibly worry about it unless I also see concomitant heart function being reduced, which is actually a cardiomyopathy. Then this is her MRI, and kind of show the same thing. The recenses can be seen here as well. And we use cardiac MRI in our patients, particularly post-delivery. There's a particular kind of contrast that we used with MRIs, and we don't use that during pregnancy because we don't know the effects on the child or when we use gadolinium. So it is usually used after the patient has had a delivery. If we do it pre-delivery, we don't use the contrast agent. So the contrast agent tells us if there is scar or not, or if there's inflammation or not, because this condition can be mimicked by other conditions. Let's say if somebody had viral cardiomyopathy, influenza B was causing a lot of myocarditis, active inflammation of the heart recently, and we've seen a few women actually die of that condition, not too long ago, just within the past year. And so it's very important to differentiate why she had a declined EF. So moving forward, the definition of peripartum cardiomyopathy is basically a form of systolic heart failure, meaning your heart function reduces, or the left ventricular ejection fraction reduces, affecting childbearing women during pregnancy or in the early postpartum period. In the past, there was a very specific definition that was used, that was the last trimester and after the first month, but that led to a lot of misdiagnosis or underdiagnosis of this condition. So now they say they've made it a little bit more vague, saying towards the end of pregnancy, but an early part of postpartum period. And it is defined as LV ejection fraction less than 45%. So diagnosis should be considered when no other cause is evident. If somebody gets symptomatic to that extent in their second trimester of pregnancy, that probably is not peripartum cardiomyopathy. That could be that they already had an underlying cardiomyopathy that just manifested with all the fluid changes that you undergo with pregnancy. You become more fluid overloaded, so you may manifest more of heart failure symptoms. And that could be just when it becomes more obvious. So timing is important, and it is a diagnosis of exclusion, meaning all other diagnoses need to be excluded first. So global estimates vary with regions. So some areas are so prevalent in this condition, 1 in 100 in Nigeria, 1 in 300 in Haiti. We think that we kind of have an idea of the incidence in the United States. It's estimated anywhere between 1 in 1,000 to 1 in 4,000, but I think it's grossly underestimated. It's far more common than we actually think it is. But the reported incidence, like I said, may not be accurate. The condition goes undiagnosed in a lot of patients. So who are at risk? So if you are from an African American ancestry, in nationwide studies in the US, greater than 40% of the cases occurred in African American women. And they can be at risk as much as 3 to 16 times higher than white women. Preeclampsia and hypertension, which is actually a very important diagnosis in pregnancy, that can lead to higher incidence of peripartum cardiomyopathy. And in one study, it was present in 22% of patients who had peripartum cardiomyopathy, compared to an average background of 5%. But one thing I want you all to remember, that while a lot of women can have preeclampsia, doesn't mean that when you have preeclampsia, this is going to lead to heart failure. Only a minority of women who actually have preeclampsia will have this condition going forward. Multiple gestations, meaning multiple like fetuses, twins, triplets, quintuplets, which can of course be, if you're going through fertility treatments, your chances of having multiple gestations are going to be higher. So that can also be a predisposing factor. Older maternal age is also associated. So the odds are 1/2 of cases of peripartum cardiomyopathy occur in the age greater than 30. And in age greater than 40, the odds are a ratio of developing is 10 times higher than when your age is less than 20 years of age. So that's something to consider, but I'm not saying that women should not be getting pregnant if they're older. My disclaimer, again, I'm not discouraging anyone from being pregnant in this room. Genetic predisposition is important because we think that anybody who develops peripartum cardiomyopathy, why do they develop it? Maybe they had an underlying genetic predisposition to it, and now they were environmentally exposed to another condition, which is pregnancy, and that's when they manifest. Because a lot of women can have preeclampsia, for instance, but they don't develop peripartum cardiomyopathy. Similarly, a lot of women get pregnant, they don't develop peripartum cardiomyopathy, so we think the genetics has to play a role. And so there was some studies done which showed that variants in a titin gene and a BAG3 gene, these are two genes already associated with cardiomyopathies, were found in these patients as well who had peripartum cardiomyopathy. So why does it occur? Again, like I said, it's kind of like a two-hit model where like you were genetically predisposed to it, and once you got pregnant, now you will manifest it because the milieu or the hormonal milieu and the environmental or hemodynamic conditions of your body change once you're pregnant. So there have been two mouse models where they looked at this fragment from prolactin. If you all remember, prolactin is something that's secreted from the pituitary gland, and it plays a very important role in lactation. So it was found that this particular fragment causes endothelial dysfunction, and it also causes cardiomyocyte death. In pregnancy, of course, if you have a lot of oxidative stress, you can see a higher number of this fragment, which causes all these changes, leading eventually to cardiomyopathy. But there was another mouse model which showed that there is a factor called the SFLT1 factor, which is released from the placenta, and that inhibits something called VEGF. VEGF plays a role in causing angiogenesis or formation of vessels. So if this pathway is inhibited, it causes endothelial dysfunction, and that eventually leads to cardiomyopathy in itself. It seems like this and this co-occur when you have this condition. This mouse model was useful because it brought into light use of bromocriptine, which is actually used to inhibit prolactation or lactation. So it's a medication that we can use now, and I'll go over some of the medical therapy for this condition in a few minutes. Other factors, some people think nutritional deficiencies play a role, or maybe somebody was exposed to a virus and they didn't know, and this was an underlying biomyocarditis that eventually led to this peripartum cardiomyopathy, or autoimmune processes. A lot of women have lupus. And just the sheer hemodynamic changes that your body undergoes. But so far, the biggest model that is being used is this model about the endothelial dysfunction and cardiomyocyte death. And interestingly enough, there was a genome-wide association study that was done, which showed that there are polymorphism in certain genes which are actually related to endothelial dysfunction also. So if you have this gene and then you get the right environment, you're going to manifest and have a cardiomyopathy. So most women present in the first month post-delivery. And of course, as I mentioned, like our patient, her symptoms had a lot of overlap with just normal pregnancy, right? She had volume overload, shortness of breath, things that you would expect with normal pregnancy also. Presentation can also be severe. So like I said, I'm a transplant cardiologist, so I end up seeing a lot of patients in cardiogenic shock, which means that they are in multi-organ failure, their heart's failing. And so there we are putting in mechanical circulatory support, trying to save them and putting them on a transplant list so they can live, or giving them something called a left ventricular assist device. Also, interestingly enough, when your milieu changes during pregnancy, you're also more hypercoagulable, which means that you're at risk of forming more clots. So this is why we see a lot of pulmonary embolism in pregnant women. But apart from that, concomitant with this heart failure, you can still have a lot of thromboembolic events, meaning women can present with a stroke, or they can present with a cardiac arrest, or severe arrhythmias is something that they can present with. So diagnosis, how do we diagnose it and how do we differentiate it from other conditions like just normal pregnancy in itself? So there's some blood markers that we can use. BNP can be elevated in preeclampsia or postpartum cardiomyopathy, should not be elevated in normal pregnancy. So that could be just a biomarker that your friendly gynecologist can perform. EKG, non-specific changes, but normal EKG does not rule out the presence of peripartum cardiomyopathy. Echocardiogram will demonstrate, like I mentioned earlier, the echo showed LV and RV dilation and dysfunction, and there can be mitral and tricuspid regurgitation, pulmonary hypertension, and left atrial and right atrial enlargement. And cardiac MRI is very useful because if you see scar, particularly with peripartum cardiomyopathy, we don't see scars. So then your suspicion is that there's something else going on. It just manifested itself during pregnancy. And again, the gadolinium contrast agent we do not use during pregnancy. In some instances where we suspect that there might be some viral myocarditis going on, we would perform an endocardial biopsy in these situations to make sure this is not an inflammatory condition which we can treat otherwise differently. But any number of things can happen during pregnancy. So women can have Takotsubos, which is stress cardiomyopathy, which means that your body undergoes so much stress that your heart function declines. And then it recovers after the stressor is over. So women, of course, during pregnancy are stressed anyways, and then if some other kind of stress happens, let's say we had a patient whose cat had died and she had the significant stress from that alone, and she developed a stress cardiomyopathy. Usually it's a good type of cardiomyopathy where it reverses back to normal. You could have pre-existing familial cardiomyopathy or preeclampsia that can predispose to depressed systolic function in any case. All these other types of cardiomyopathies can also occur, and women may have valvular heart disease, congenital heart disease, meaning you're born with a certain type of heart condition, tachyarrhythmia-induced cardiomyopathy, hypertensive heart disease. Again, a lot of women are getting pregnant at a later age, so they could have pre-existing hypertension or diabetes. And cardiomyopathies can be related to certain systemic medical conditions like lupus or sarcoidosis or hemochromatosis, which could also be in the differential. And then, of course, pulmonary embolism is common in patients who are pregnant, so it could lead to dyspnea and tachycardia and depressed EF also. So outcomes, so major adverse events, of course, could be very serious complications like brain injury or arrest. Could have pulmonary edema, meaning your lungs fill with fluid and you need to be on drips. Thromboembolic complications, a lot of women have an LV thrombus, meaning because the heart function is depressed, you'll see a clot in their left ventricle. And cardiogenic shock, which is the dire form. So 60% of cases of cardiogenic shock during or shortly after pregnancy are related to peripartum cardiomyopathy. And we've had a certain situation in our hospital where a full-term pregnant woman came in the final trimester and had cardiogenic shock, and then we had to support her with temporary mechanical support. And eventually, she gave birth in the hospital while on that balloon pump support. Mechanical circulatory support, or something called left ventricular assist device, something that we can do for patients, and cardiac transplantation. Death, 4 to 11% in the first year after this diagnosis, and 0 to 16% 2 years after. So it's not a benign condition by any stretch of imagination. And then recovery, believe it or not, while this sounds very grim, there's a good number of women that recover their heart function. And then if they get pregnant again, they're exposing themselves to the same environment again and can have depressed ejection fraction again. So those are important conversations to hold with pregnancy women who want to be pregnant again. And recovery usually happens within the first 3 to 6 months. And it has a higher rate of recovery compared to other forms of cardiomyopathy. So usually I give a lot of hope to my patients that you may recover in 3 to 6 months on appropriate medications. And then after that follow-up, we talk about medications and how to handle that. So what are good prognostic factors or poor prognostic factors? So if your LVEF is reduced, the lower your heart function, the worse are the outcomes, and lower your chances of recovery also. If you have presence of the LV dilation, meaning your heart's big, or LV thrombus, meaning you have a clot in your heart, or you have right ventricular dysfunction concomitantly, obesity is associated with worse prognosis. Also, African American ethnicity. So it's strongly associated with lower rates of recovery and a longer recovery time, more adverse outcomes, and higher mortality. And presence of preeclampsia, actually, if you have that, it lowers your 1-year survival. But interestingly enough, if you do have preeclampsia, your rates of recovery are higher, because I think with preeclampsia you have a modifiable condition that you're working towards. And once you lower the blood pressure, maybe that also reduces the stress on the heart. And biomarkers, of course, if you have an elevated BNP or troponin or this SFLT1 that we talked about earlier, that are associated with poor prognosis. So medical management, so whenever we have women that are pregnant or of childbearing age and they have heart conditions, we really have to be cognizant of what we can give them or what we should not be prescribing to them. So these are a list of medications that are okay to prescribe, which includes loop diuretics, beta blockers, hydralazine and nitrates, and digoxin. There are, of course, some things to be cautious of. Of course, you don't want to drop the blood pressure too much because that reduces the perfusion to the child. You could have things like intrauterine growth retardation, fetal bradycardia, and hypoglycemia, particularly with the beta blockers, but the rates are lower. That's why these medications are still in the green. And then hydralazine nitrates can cause hypotension. Be very careful. And digoxin is safe to use. There are no associated congenital defects. Again, with lactation, they're still in the green, but you don't want to dry out your post-pregnancy, you don't want to dry out them too much if they're lactating. And then not reducing the blood pressure too much because, again, you're lactating, you probably need some blood pressure to work with. So these are in the red. These medications should not be used because ACE and ARBs are associated with these congenital anomalies, anuria, oligohydramnios, fetal limb problems, craniofacial deformities, so absolutely no. And again, when I even see patients who are of childbearing age and I'm treating them for cardiomyopathy for other reasons, I make sure that they are on contraception or some form of, so we can take these medications off if they want to be pregnant. Again, spironolactone, which is an aldosterone receptor antagonist, it's associated with feminization. So basically, again, contraindicated. Sacubitril valsartan Entresto is a new medication on the block, but the effects are similar to ACE and ARB, so we extrapolate that it will cause the same problems. And ivabradine, there's scant data on humans, but animal data suggested there's risk, so we don't use this. So, but things can change when you're lactating. So enalapril and captopril can be used during lactation because now you're past the point where the baby is forming or developing, so you may not have as much congenital abnormalities. And spironolactone can be used in lactation. So medical management, one other important thing to consider is that because the pregnancy is a condition where you're at risk of having clots, you have to be anticoagulated as well, particularly if your ejection fraction is less than 30%. That's what the European and the American guidelines are leaning towards. The EF has to be a certain number. Below that number, you get anticoagulated. But it has important bearings because warfarin, which is an anticoagulant that women with valvular heart disease are also using, or that can cross the placenta, and it can cause embryotoxicity. So we can't use that. Low molecular weight heparin does not cross, and that can be used during pregnancy. Both warfarin and low molecular weight heparin can be used during lactation. Then comes the story of bromocriptine. This is the medication that I was talking about earlier. So this has been used in certain South American study, African study, where they showed benefit of using this medication. The only problem with that is that it does increase your risk of hypercoagulable state. So you're at risk of having blood clots more than you already are. So definitely women who are on bromocriptine, we put them on this medication. However, randomized trials are still lacking, so there is a trial called Rebirth that is going to be started in the US and Canada. And so that might be helpful for future if women, this medication should be used or not be used. But it has shown benefit in some other populations. No big studies have been done in US or Canada. Do I use it? Yes, in particularly women who are not going to lactate. But if you're going to lactate, if you use bromocriptine, then we have a problem. Then we can't use bromocriptine in that situation. So advanced heart failure therapies, patients can receive something called a left ventricular assist device, which is essentially a pump that goes into your left ventricle and pulls out blood from the left ventricle and basically puts it in the aorta. And so it takes over the function of the heart, so to speak. The good news is that people who were on an LVAD with pericardium cardiomyopathy, 6% of them recovered, which means that you can take the VAD out afterwards if they've recovered. And 48%, however, went to cardiac transplantation. When people are undergoing transplantation, many things are under consideration. One of which is that, you know, if you have pre-existing antibodies, which unfortunately women who've had pregnancy, they will have more pre-existing antibodies because now they're exposed to the antigens from the child. So that leads to problems when we're trying to transplant women, which is a very important consideration, in particularly pregnant women. But if you look at in general of how pericardium cardiomyopathy does in comparison to other types of cardiomyopathies, you see the survival curve is much, much better than other forms of cardiomyopathy. So pericardium cardiomyopathy still is a form of cardiomyopathy where I tell my patients that, you know, all hope is not lost. You could still do really well. So we just have to get on it sooner, make sure we make the diagnosis correctly, don't undermine symptoms that pregnant women are telling you about, and then treat it in an appropriate time so that, you know, they can have a better prognosis. Labor and delivery, it has to be a cardio-obstetrics team of experts, meaning a cardiologist at high risk, OB, maternal fetal medicine, anesthesiology, nursing, pharmacy, you name it. It has to be a full village taking care of women with this condition. We do consider early delivery if there is hemodynamic compromise. If you're chugging along, you're feeling okay, you're tolerating the medications, we're not going to do an early delivery. We let you complete the term. C-section versus vaginal, again, if you're stable, vaginal delivery is encouraged because with C-section in itself, there are other problems because, you know, you can have a hypercoagulable state again from having the stress of the surgery. Breastfeed or not. So there was a European statement on pericardium cardiomyopathy which advised against breastfeeding. But there was a small study that was done in the United States which indicated that women who actually breastfed had a higher rate of recovery. So it was essentially, it gave us a good signal. And there was recent data which showed that breastfeeding was not associated with adverse outcomes or inflammatory markers or persistent myocardial dysfunction. So breastfeeding is considered to be safe in pericardium cardiomyopathy. And it seems like despite continued stimulation of that prolactin and that fragment that was being produced, it doesn't cause worse prognosis. So if women are interested in breastfeeding, then we encourage it. I do talk to women about bromocriptine as an option for treatment, with, of course, the lack of big trials to prove that it is useful. Then some women want to be on it and some women do not want to be on it. It's always a choice that we talk about because we don't have big data or very strong studies to back that option. Contraception has to be discussed prior to the hospital discharge. We tell them to avoid estrogen-based, again, because of the risk of thromboembolism. Progesterone-based or IUD are safer. So why we do encourage contraception is that if you have pregnancy in the future, you could have more severe LV dysfunction. So what plays a role in making that decision, whether we encourage you or kind of discourage you from having pregnancy in the future, is this golden number of ejection fraction. If your ejection fraction has recovered and it's greater than 50%, which is in the realm of normal, you could have another pregnancy perhaps safely. Of course, you have to undergo all these visits. There's a chance that there's a 20% chance of having a relapse. Severe deterioration, however, if your ejection fraction has recovered, is lower. Mortality is unlikely. And a rate of subsequent recovery after you've delivered is still going to be high. But if you're somebody who belongs to this group where the EF was less than 50%, even after you recovered, That's high risk of relapse. 50% show further deterioration in LV dysfunction. There's increased morbidity and mortality, and premature delivery and abortion are common in these patients. Medications, we continue, same medication, a little bit more aggressive on this side when you have less than 50% EF. And then follow-up, we do close monitoring, we do biomarkers, we do echocardiograms at every trimester. And labor and delivery, it has to be a multidisciplinary team approach where you have to go to a high-risk OB, where a cardiologist, particularly a heart failure cardiologist, needs to be on board when we're going to plan this delivery. So it has to be more than just your obstetrician. And so basically, clinical assessment, echocardiograms, when do we do that? Prior to contraception, end of first trimester, second trimester, 1 month post-delivery, and after discharge from the hospital, because like I mentioned, it usually develops around this time, but if you're planning a subsequent pregnancy, it could, could have an EF that becomes depressed even earlier. So back to our patient. So we started her on appropriate guideline-directed medical therapy. She was started on bromocriptine. She decided on not to pursue lactation. She was started on anticoagulation and a blood thinner. Importantly, of course, it's a condition where you're at risk of having arrhythmias, but before we commit you to something called an ICD, which is a defibrillator, which stays inside your body, we try to do something called like a life vest, which is not permanent. It's like a bra you wear. And if you go into an abnormal rhythm, it will shock you externally without having an internal device. And a lot of women recover, so they eventually don't need that ICD. So it's an important discussion to have. And in my patient, so the question really was whether this was non-compaction versus it was peripartum cardiomyopathy. And it's something that only time will tell, right? Because if she recovers, she probably falls into this category. And remember when I talked to you about the trabeculation, if they recover and become smooth-lined again, it's probably all pregnancy-related changes. But could she have non-compaction? Sure. That's why we instructed her that she needs genetic testing. She needs a good family screen, genetic counselor on board to make sure that this is not a pre-existing condition that just manifested with pregnancy. So it's important to have those discussions as well. So with that, I will end my slides. If you have any questions about pregnancy and cardiomyopathies or any other pregnancy-related questions, I'll try to answer them to the best of my ability. If there's anything, please go ahead.
So okay. I have a friend who, in her second pregnancy, had a C-section. They saw something abnormal during the C-section on the EKG, and she was diagnosed with a ARCV. And I just really, is that a condition where it's more genetic?
Yes. So ARVC is a type of cardiomyopathy which is genetically mediated. We'll go back to one of the slides here. It's called arrhythmogenic right ventricular cardiomyopathy. So in these patients, we make sure that we get a very good sense of their family history, genetic testing, and then echo findings. But it's a very hard diagnosis to make because you have to meet a certain criteria. And you cannot make the diagnosis based off just a genetic test. Let's say if she was suspected to have ARVC, she has to meet the clinical criteria of ARVC. We cannot do a genetic test to confirm that because a lot of people in the general population may have that gene that's positive, but the gene may not manifest itself. Actually, the ARVC gene, if you have the variant, it's very low penetrant, meaning that it has the chances of it manifesting are actually very, very low, even if you have the mutant variant of it. So it's a very tricky diagnosis to make.
So would pregnancy have caused that to manifest itself, or you really don't know?
So pregnancy may, if you already have ARVC with the phenotype, meaning you have depressed ejection fraction or right ventricular dysfunction or arrhythmias that are basically how ARVC is, if they manifested with pregnancy, it is a possibility. But you never know when she first started. Again, like I said, women don't know when they start having shortness of breath. Is it pregnancy? Is it them? Their heart's racing. They don't know if it's arrhythmias or is it truly them. So that's always a tricky part. But the true question can be answered by doing an MRI or an echo and trying to see if she fits the clinical criteria of ARVC. And a lot of women do manifest, or their underlying clinical condition can manifest during pregnancy because, again, it's a stressful condition to be in.
So why don't women get a baseline echo if they know they're going to start planning a family? Is it just like the number needed to treat is so low that it's not worth it, the insurance companies aren't going to pay for it? Or
That's a very good question, and something that we debate about a lot in cardiology, because we see the very sick ones, right? So our bias is everyone should get an echo. Why not, right? I think, there has to be, of course, we have all these screening tools these days. I think, in my mind, we can't generalize to everybody, particularly in younger patients. It's such a rare event. If you were, let's say, in Haiti or Nigeria, I would say yes, women should get a baseline echocardiogram because it's so common over there. But in the United States, first we have to really establish how common is it. And knowing these pre-existing or predisposing factors, I think if you are somebody, let's say if you have no other risk factors, but you're just older and you're about to get pregnant, I think it's a good idea to get a baseline echocardiogram because, the older you get, the more, your cardiovascular disease risk increases anyways. So that might be not a bad idea to get that, but it's not in the guidelines yet. Again, it becomes a healthcare cost burden versus should we generalize doing everything to everyone. Maybe in the future that will be the case, once you're going for pregnancy, maybe everyone will get an EKG, an echocardiogram, and all these and some tests. Maybe it'll just be a simple thing, a blood test, that they could just do and see if the BNP rises. Maybe that would be indicative of something moving forward. But it's a great question, and I think it's discussed a lot in like different committees and whether we should do echoes on every pregnant woman. Probably it's not warranted in every woman, but it's something to consider in people who have risk factors. Any other questions? So one of the important ones that I didn't go over is spontaneous coronary artery dissection. So it's a condition which is very specific to pregnancies, is where your coronary arteries can dissect, causing a heart attack when you're pregnant. And we see that, every year we see 1 or 2 cases where present with heart attacks, and it's a spontaneous dissection. Usually we treat it conservatively, meaning you just let it be, and they're monitored in the ICU, and it heals on its own. But sometimes it can be very dire because if a lot of your coronaries, there are 3 main vessels. If 2 get dissected, then you have ejection fraction that gets reduced. Then we're talking about ICU, putting down some kind of mechanical support in the meanwhile while they recover. But that's also an important condition to know about. That of course gets missed also again, but it's very, that one is more manifest because you have excruciating chest pain. So, you probably present to the hospital with a heart attack, and it's usually a young female with risk factors for this. I think there's a question over there.
Okay, so I'm in the neonatal ICU, so we do see a lot of the pregnancy-related things. My question is, in our area, on the childbirth center, they have always mentioned that the African American women are very high risk of dying from pregnancy. And now that I know African Americans have a higher problems with heart, I'm just wondering if it's related to, the mortality of them getting pregnant, being predisposed with cardiac disease also.
Right. I think it has to probably, do with that, of course, when you're seeing, they're more at high risk of having peripartum cardiomyopathy. Let's say it went undiagnosed when they had it, and then you're seeing, somebody who died after delivery. It could be related. It's just that, like, we mentioned earlier, we're not doing echocardiograms on all the patients. So, maybe in the future what we could develop is a risk system where we could say that if you're, based on how much risk you get from a certain condition, like if you are African American and your risk is 3 times higher, you should get 3 points for that. If you have preeclampsia, you should get another 2 points, 5. So if your underlying score for having some peripartum cardiomyopathy is high, then you should undergo an echocardiogram. Now, it could also be related to hypertension because a lot of African American women are also more likely to have high blood pressure. So that also increases their risk. Having said that, I mean, of course, we see it in I've seen peripartum cardiomyopathy in white females and Hispanic and Latina females. So it's all across the board. We see it in a lot of populations, I think, and it has to do with genetics also, like if you're genetically predisposed to a certain condition. But it's an interesting thought. But I think if we can come up with some kind of risk assessment and we can just use that score to determine your risk and do an echocardiogram at that point, maybe we'll be able to nip it in the bud then. Any other comments? When women who are pregnant come to us, I'm a little scared of them, you know. I don't necessarily want to take care of them, like, oh, should we be doing this, should we be doing that? But over the years, we've seen them in very serious situations, and it's really helpful to have a very good, high-risk pregnancy, maternal-fetal medicine people on board with us, because anything we do, we always talk to them and have discussions about it. I have a few patients in clinic that I see for peripartum cardiomyopathy, some of who have recovered very nicely, some who I have to keep arguing with about subsequent pregnancies, tell them not to get pregnant. It increases my blood pressure by 10 points. But there's of course there's people want to get pregnant in the future also. We don't discourage it completely, but like I said, if you fall in the category of not recovered your heart function completely, we discourage it in that situation. But then I watch them like a hawk. I have to follow them very closely, make sure they're doing okay, their heart function is being watched closely enough so they don't have troubles. But certain heart conditions like pre-existing heart failure in itself, if not from peripartum cardiomyopathy but from something else, congenital heart disease, pulmonary hypertension. Pulmonary hypertension, some of these conditions we tell people to not get pregnant if they can avoid it, because the stress of pregnancy is exponentially higher in those women, and some of them, particularly ones with severe pulmonary hypertension, we actually, if they get pregnant, we tell them to, it's a threat to their life. So it's that big of a deal actually in that situation. Any other questions? I'm just trying to fill gaps here.
You mentioned earlier that you encourage vaginal deliveries if the EF is preserved enough,
or they're hemodynamically stable. So let me, this hones in on an important point. So your EF could be less than 20%, but your state could be compensated, meaning you're still going around doing things, your heart's still able to eject enough blood forward, and the pressures inside your heart are not too high. Okay. But you could have a decompensated state, which means that you're huffing and puffing with walking short distances, your pressures are really high, the amount of blood that your heart's putting out is very low. That state is not safe for vaginal birth. The state when you're stable is safer. But if your ejection fraction is very, very low also, it can be a little bit of a tricky vaginal birth. But having said that, I mean, there have been some successful vaginal births with even low EFs. It's just how they are when they, in terms of how compensated they are. So if their heart's putting out enough blood, and we're monitoring it closely, where we use cardiac anesthesia on those patients, then you can safely do maybe a vaginal birth.
Even with mechanical assistive devices?
So mechanical assist devices, you in those situations you would proceed with C-section, because then you have a mechanical pump, you're on blood thinners, it becomes a little bit more complicated.
Okay,
yeah.
Thank you.
Yeah.
That's our time.
That's our time?
Thank you.
Awesome, thank you.
time to take us through a guided meditation, which is incredible. But anyway, stress is reduced by exposure to nature. For cardiovascular disease, the risk caused by stress is equal to smoking, elevated fats, hypertension, and diabetes. Though stress may also affect these behavioral risks, these factors don't explain the increased risk of cardiovascular disease caused by stress. Dr. Cooke, who is a reputed professor at Harvard Medical School and a cardiologist at Mass General, was at a symposium for our Center for Health and Nature, and he had done an inner heart study that looked at the impact of stress on cardiovascular disease, controlling for the other risks that we just talked about: smoking, hypertension, lack of exercise, diabetes. And you know what he found? He found that stress counts for an independent risk factor for cardiovascular disease with a roughly 50% increase. Huge. Now, if nature can have an impact on reducing stress, which the science is proving, we should all go out and partake of more of it. Research shows that exposure to nature reduces stress, but this research has been sort of cloistered in the university systems. It has not been an interdisciplinary program that, like what we've created in 2018, to study the impacts of nature exposure on a vast number of health and heart and other diseases. For example, health impacts of nature, and I had an article that I was going to share with you all, but we had a number of people at the last session, and I don't have any more, but if you're interested, I can get you one. But 5 minutes of outdoor exposure, your self-esteem and your mood start to rise. 5 minutes out in nature. In 10 minutes, your ability to focus improves. 20 minutes, your energy and vitality levels skyrocket. In 30 minutes, happiness increases, your symptoms of anxiety and depression and blood pressure are all improved. In 90 minutes, the blood flow to the frontal part of your brain improves, and that's an area that's involved in depression, stress, negative thinking. Nature does and impacts all of that. In 3 days, your killer cells skyrocket, and those killer cells are critical to addressing the inflammatory response, which is at the heart of all disease, including cardiovascular disease and inflammation. And these effects have been shown to last for substantial periods of time after that exposure. So you ask, why hasn't the evolution of this research gone forward? And I have to say the reason that the research into the mechanisms in nature that promote health, healing, prevention, wellness, and reduction of stress, improvement, and prevention of cardiovascular disease, the reason it didn't go forward is because the research was siloed in universities and it lacked an interdisciplinary approach. But that has changed. That has changed because in 2018, the three partners I mentioned, Texas A&M University, Texan by Nature, and Houston Methodist, created a partnership. It is now housed here at the Research Institute, and that partnership is requesting grant proposals from people who are doing research on the impacts of nature on a whole array of diseases and the impacts on prevention and wellness. Is currently co-chaired at the Center for Outcomes Research, is co-chaired by Dr. Beta Cash, who sits on the Innovative Healthcare Delivery Systems boards of the NIH, and Dr. Nasser, who you may listen to today. He was recruited by Dr. Zogby, co-chair of the Cardiovascular Center, to address the prevention of cardiovascular disease instead of just looking at what do you do after you've already gotten it. So I have to say, I believe that this Center for Health and Nature is divinely guided. And you ask, how could I be in the middle, big fat middle of this and pushing it forward. Well, I have a passion for nature, I always have, but it was really fine-tuned and taken to the highest level after my mother passed away. And I say she's a high angel in heaven with her boots on, and she's booting me, and she's sort of kicking me to keep going and moving forward. Because it takes sort of a different approach to putting this thought out there. And there is so much reception in the world to what we're trying to do here. There is nothing like this combination of interdisciplinary work anywhere in the world. And we are housed in the leading medical facility and hospital in Texas, nationally ranked in so many other areas, including cardiovascular disease. And they say Methodist is leading medicine, and it is. It's willing to look at ways to put itself out of business, even with this health and nature initiative that we're advancing. So in short, we expect physicians will be writing prescriptions for time in nature. We're in talks now with the Houston Parks Boards and others on the BioCity Greenways initiatives. Right here in our own city, we have miles of paddling, miles of walking trails, and they're going to grow. We have vertical and horizontal integration of our Greater Houston partnership, quality of life folks, along with the large foundations in Houston, along with Houston advancing the miles, working with the flood control districts to create more urban green space for people to take. And we at the Center for Health and Nature are going to be the repository of the research that convinces people that they need to get out in nature, but they need to protect nature because their health and well-being depend upon it. So stay tuned. Please do try to take a look. An awful lot of information on there about the status of some of our research projects, which will be reported out again at the symposium in October. But I want to yield the rest of my time to Dr. Ford. She's going to take you through an amazing journey on guided meditation. And thank you so much for hearing me. Let's save questions. Let's go meditate. I was really doing well. I got a whole 8 minutes. I want another 8 minutes. All right. Thank you, Cynthia. Thank you.
I guess right here. No problem. Okay. Oh, yeah. Oh, okay, I'll do that. Thank you. All right, thank you. All right. Hi, everyone. Okay, thank you for being here. I always get to be the end of the day, and I happen to be a dentist, so nobody likes being the end of the day, and nobody likes going to the dentist. With that said, I hope that I can keep your attention long enough for you to meditate. My name is Dr. Inge Ford. I am a native Houstonian, and the ya-ya is because I'm a grandmother, and I don't allow them to call me the G word. So, how I got involved with yoga is I was practicing yoga from the time I was in college many moons ago. Life got in the way. Subsequently, multiple children. I have 4. I had some health issues, and it was before I was double nickels, aka 55. I was falling apart, and I was like, what the heck? What is this all about? So I decided to get serious about getting back to my mat. I mean, I had a hip replacement, I had cervical neck surgery, and I was in pretty good shape because I eat well, you know, the whole gamut. And I really started looking at the science of mind-body. And what I remembered back from the time I was 18 that I really didn't take it seriously, and then having some opportunity to travel, I realized that Eastern medicine knew a lot of things, as do your grandmothers and great-grandmothers, most of you, great-grandfathers too, and grandfathers, that there was old school wisdom. And everything really revolved around prana, this concept of breathing, because most of us don't breathe. We breathe just enough to live, but we don't really fully breathe. And nature is such an important part of that, because nature's bounty, every time we walk outside our door, provides everything that we need to support us, to be healthful, of mind, body, and spirit. So I hope that I can share some things with you, and please feel free after the meditation to ask any questions. I am not so well learned. I learn something every day, but I have trained extensively and trained abroad in India as well as Africa to learn more about this concept of nature and how it affects our health. Oops. So, what is your concept of meditation? Anybody? Do you think you have to be? Yes. Okay. Okay. That's basically true. But the truth of the matter is, it's hard for us to sit still and be perfectly quiet, isn't it? Our thoughts, we have thousands of, you're probably thinking right now, when she's finished, how am I going to get to that parking lot fast enough? Which way am I going to go home? Am I going to stop and get a little extra dessert because I had a nice lunch, but I probably didn't get an extra cookie? You know, whatever it is. So you're having constant thoughts even as I speak to you. But the truth of the matter is mind over matter. You've heard this many times, but the heart is really the center and access is the wisdom of the universe. Our feeling emotions are here. And if you had the opportunity to hear Dr. Quinones, which I did, and he plugged me very nicely because he said that meditation is important to lower stress. I was like, did I pay that guy to say that? It was really awesome. But the science and the research is here. And what we recognize is that when we lose our connection with nature, the very thing that supports all of our being, whether it's the food of the land, the air that we breathe, the water that we drink, when we have that disconnection, that we are actually kind of giving a little injury to our bodies. But the moment, as Attorney Pickett reminded us, the moment that we have these few minutes, it could be as little as 10 minutes, 30, or an hour, days. It can change our whole being and the stress levels within our heart. So nature does provide that nourishment. So what we do know is that any experience that any of you, and myself included, experience or have really works on the process of the 3 states of the mind. We have the unconscious mind, that's the autonomic, that allows us to breathe, gives us signaling when we're hungry. It's the non-thinking mind. It's the one that carries us through the mundane processes of what we routinely do. But our perfect well-being is really left to chance because it's really not absorbed in making sure that we do 100 push-ups versus 30. It really doesn't do that. And then the aware state, that's where you are now. The aware state is kind of your reflective mind. It's like, I don't know, do I want to wear red or blue? It's Valentine's. It's really kind of giving those little signals, all right? And it's basically called your true self. This is what you respond and react to. So it is the unconscious mind, the one that's autonomic, and the aware state that are actually highly developed. But then there's a third state of mind, which is your self-aware state. This is the one that I battle with sometimes, and I think many of you do too. The desserts at lunch today were really, I just kind of wanted to fill up my plate. But I know how I feel when I have that much rich dessert on board, how I feel. So my self-aware state says, okay, girl, you can have maybe half of that cookie, share it with your daughter here, but you don't have to have 3 of them, all right? So it's the one that questions patterns and behaviors. Sometimes many of us know better, but we still don't make good choices. Anybody can relate to that? And it shifts the non-functional behaviors to the aware state. So when we're experiencing anything or if we make any decisions or whatever, we're engaging these 3 states of mind. So how do we shift problems to solutions? What are some tools that we can do? Just note, your body is dynamic. You're not the same as you were half an hour ago, from yesterday. Anything that, because it's not static, anything that is constantly moving is constantly changing. So we do have the opportunity to change patterns and behaviors. It's a choice, but we do need some tools sometimes to help. So when we're talking about breathing and meditation, let's try to create new pathways in the mind. And that can be something as simple as just being more observant. Random acts of kindness, compassion. I love riding the rail. Many of you ride the rail here to work. Some of you don't like it because there's some unsavory characters from time to time. You know who they are. But, you know, honestly, that doesn't bother me. What I always do is speak to them. That creates a whole mood shift in even their behavior to me. So practice gratitude. Many of us probably eat on the run. Many of us don't have an opportunity, even though there are green spaces here in the medical center, just to eat outside. Perhaps just taking the opportunity of taking that brown bag sandwich to a little place of green space, eating mindfully, slowly, having a connection with another being. Not digitally so much, and I'm not against digital, that's just another platform, but to have that connection between nature and another being creates this small little steps of just being aware. And as you learn to cultivate these small changes with ease, you actually become more adept in making yourself more meditative. Does that make sense? Okay. So, I'd like to prepare you for meditation. Believe it or not, this Western version of yoga, where everybody's going to the yoga studio with their cute little mats and their cute little clothes and all this kind of stuff, that's really not it. All of you in this room are actually yogis. The physical aspect of yoga is really just one part of it, but the whole concept really came about meditation. To being a little quieter, to be able to be introspective, to actually create a change of not only your blood chemistry, but to actually be more attuned to not only nature, but to others. And so this concept of asana practice, the physical part of yoga, came about because the teachers realized, especially here in the West, that a lot of the students had what they call a monkey mind. It's always jumping around. But the mind does that anyway. But it was jumping around in such a way that they couldn't sit still. So wearing them out, kind of quieting them down. When you have shavasana, how many of you have been to a yoga class? You know, that's the quiet part. So don't you feel good after you do that? And there's a reason for that, because you're breathing with movement. So also when you prepare for meditation, it's ideal to set what we call an intention or a centering thought. It could be something as simple as when you park in the parking lot to come to your place of work here, that you park a little farther away. And I'm going to set an intention to get in an extra few steps, so I'm going to park a little farther. And then to be able to sit comfortably. Do you always have to sit? No, you could lie down. You can find any position that's comfortable for you. And also to develop a mantra. A mantra is a saying or a phrase or something that can bring you back when your mind seems to wander, if you're sitting in a state of quiet. Today we're going to practice one called So Hum. So Hum. So Hum. It just means I am. If you don't like that one, come up with your own. My personal favorite is Okie Dokie. Sometimes I'm sitting at the intersection and I've missed 3 light cycle and I'm just going okie dokie, okie dokie, okie dokie. That's a form of meditation. I'm just calming it down. Eating a meal with your family or friends. Meditation is a host of different things. It's not necessarily sitting perfectly still and perfectly quiet. And breathing. How many of you think you know how to breathe? Oh yeah, no fair. That's my kid. Nobody? Okay, so I challenge you. Actually, can you give us a little information of what you think breathing or how to breathe is?
Okay, more relaxed way, probably you have to use your abdomen to breathe. And because we are kind of limited on our chest. So, and especially we are women here, only one gentleman in the back, and we all trying to kind of wear kind of more feminine ways, and some of the clothing are really restricted for us.
Thank you. She's absolutely, if you didn't hear what she was saying, is that many of you are sitting, we don't fully breathe. We never fully inhale unless we consciously do it. I won't say never, but many of us don't, all right? And so because we tend to sit in a concave manner, we sit in our cars, we sit at computers, we don't fully sit in a way that allows our rib cage to lift, our diaphragm to fully expand so that our lungs can expand and take a full breath. Breathing changes your blood chemistry. Did you hear what I said? Breathing changes your blood chemistry. If you're not fully oxygenating, your blood level is probably running at a more acidic pH level. Inflammation and dis-ease lives in acid. If you're in nature and you're able to fully breathe and expand, you can oxygenate your blood more, and your blood level will be slightly alkaline or on the higher side of an alkaline measurement. Nothing but good stuff can live there. You can change your blood chemistry by breathing. So let's breathe. So before we start, I'm going to ask you to, if you're sitting real close, to kind of move away from somebody a little bit so you won't be super close. Push your seats back where you can sit towards the edge of your seat with your feet level onto the floor. You can place your hands on your knees. And like the member in the audience shared with us, more abdominal breathing, we're just going to exercise that, and then I'm going to give you a form of exercise that will kind of like get your heart rate up just a little bit so you can see the difference, all right? Humor me. And if you have questions, ask questions later because I really want to hear them, all right? So what you're going to do is have your hands, palms on the top of your thighs. You can have them palms down, palms up, whichever. I'd like for you to close your eyes. As you close your eyes, I'd like you to soften your jaw. Perhaps maybe let the floor of your tongue just get heavy, the tip of your tongue maybe gently behind the tops of your teeth, the back of your upper teeth. And as you breathe in, see if you can imagine your belly as a full balloon. Breathing, allowing your belly to expand fully, letting that breath, imagine, rise up through the chest, the rib cage, holding it maybe to the tip of the lungs. And as you exhale, exhale the same way you took it in, from the belly, the chest, the tip of the lungs. See if with every exhalation you can go slower, softening your shoulders, softening your jaw. Breathe in again. You don't necessarily breathe when I tell you, but just where your body will allow it. But at the top of that breath in, hold the breath for a second, maybe 2. As you release it, slower than you took it in, imagine your navel touching the front of your spine. Do that one more time, and this time on your exhalation, I'd like for you to part your lips and give a gentle ha, a sigh breath out. Empty, empty, empty. Open your eyes and just witness how you feel. That was okay, I guess, a little boring. So how about standing up? We're going to do something called a Kriya. A Kriya, a cleansing breath. Give yourself a little room from your partner or next door neighbor. And I'd like for you to place your elbows close to your rib cage with your palms up. As you breathe in, you're going to raise your arms up. As you exhale, you're going to draw your elbows back. So it's do it with some force. Keep going. Do it like you mean it. Come on, you can do better. I know it's the end of the day. And let's move it. Let's pump it up. Keep going, keep going, keep going. 1 more, 2 more, 3 more. Last one. Close your eyes. Place one hand over your abdomen and the other right at your navel center. Close your eyes. Perhaps your heart rate came up just a little bit. Witness how you feel. Now I'd like for you to sit back down. As you sit down, did anybody feel anything? Tingling in some fingers maybe? Maybe your heart rate got pumped up a little bit? Good. As you're now sitting, I'd like for you to consider this thought, this intention. I am a grateful expression of nature. I am a grateful expression of nature. I am a grateful expression of nature. With that intention, we'll enter into our meditation. If you find your mind wandering and going, ooh, this is, ooh, you can either say so hum, a mantra of your choosing, or okie dokie. Allow yourself to come to the edge of your seat where you're on what we call your sits bones. Don't sit fully back. I'd like for you to sit where it'll allow you to tilt your pelvis a little forward, which by doing that will allow your spine to straighten. Allow your shoulders to come away from your ears. If that's not comfortable, use the armrest. You can have your palms down or palms up. I will ring a soft bell at the end of the meditation, at which point you will release the mantra, release the intention into the womb of the universe. We'll talk about that, okay? When you find yourself getting impatient, come back to your mantra. So when you're ready, close your eyes, breathe in, breathe out. As you breathe in, breathe out softly. Soften your jaw. Begin.
Release the thought. I am an exquisite and grateful expression of nature. As you begin to gently flutter your eyes open, witness how you feel. Perhaps sit back in your chair, rest. You can call upon something like this any time of the day. You just meditated for 8 minutes. I can't wait a minute sometimes at the microwave. But you just sat still. I don't know what your mind was doing, only you know that. But perhaps what you might recognize is how maybe a part of your body might feel softer, maybe less stressed. And again, it's not anything that we don't have available to us. It's not anything that you have to spend a lot of money for. It's just a tool. Would any of you like to share any of your experience? Or have any questions?
I can just say that I immediately started feeling very relaxed and even some tingling in my head. It was just relaxed.
Did you feel that during your meditation, perhaps when you did the little Kriya part right before you sat?
During the meditation.
Okay. Could any of you tell the difference between when you just began to breathe based on how I was instructing you to breathe just a little bit more fully versus how you felt after you did the Kriya? Did anybody feel any different in terms of how your breath was? Or maybe it was more full?
Yeah, I just felt more awake after we did the Kriya.
Okay, good.
You know,
good.
Just like more feeling,
yes.
per se.
Yes.
Yes, more
yes.
feeling.
Yes. So really the bottom line here is the beautiful work that Methodist Hospital is doing with understanding how impactful nature is to our health and that we are actually an expression of nature is really profound. Me as a medical professional, I'm trying to figure out why we never figured that out before. Because the truth of the matter is cultures all around the world have known this, and it's really important that we grab a handle on it as we treat our patients and our families of the patients that care for them. So I really appreciate your time. I thank you. Peace. And I hope that you will take any of this information and maybe learn more. Thank you.
Thanks everyone for coming today. We really appreciate it.